Good afternoon, ladies and gentlemen. At this time, we kindly ask that you please take your seats. Our program will begin shortly.
Hello, everyone. Thank you so much for being here. Let's give ourselves a big round of applause. This is a packed room. I'm happy to see it. One big housekeeping rule before we get started. Because it is a packed house, please don't put your bags in the seat next to you. Try to make as much room as possible. Really appreciate you all being here. It's going to be an awesome afternoon. My name is Danny Nierenberg, and I want to welcome everyone who is joining us in person and online for our summit focused on advancing food as medicine in support of the White House strategy on hunger, nutrition, and health. Again, I'm Danny. I'm here with my co-founder, Bernie Pollock, who's here in the front row. Food Tank, for those of you who don't know, is a research and advocacy organization devoted to highlighting how food and agriculture can be the solution to some of our most pressing environmental and social challenges. We hope to inspire, motivate, and activate positive transformation in how we produce and consume food. I'm really thrilled to be back at the Friedman School. This is a little bit emotional for me because it's like coming home. I'm a graduate of the Friedman School. And I was really able to learn from the best minds on food and agriculture and nutrition. I had amazing professors and internships that helped me become the person I always wanted to be. I am so grateful to the Tufts community. People like, former professors like Molly Anderson, Kathleen Merrigan, Willie Lockritz, and of course, Dr. Mazafarian and Dr. Economos. I really consider them all mentors and family, or at least part of the Tufts Mafia. So thank you all. For this summit, I want to especially thank Julia Sharib, again, both Drs. Mazafarian and Economos, and Emily Callahan for hosting us and being incredible collaborators. Today's programming would not be possible without all of them. I also want to give a huge thanks to the White House Office of Public Engagement, including Catherine O'Carr, Kellyanne Blazik, and Will McEntee. Talk about people who become like family. They've been amazing co-conspirators on today's event. And I really want to acknowledge their leadership and really tireless work to ensure that the Biden-Harris administration continues to focus on bolstering food security and improving eaters' health and well-being. Last September, the White House Conference on Hunger, Nutrition, and Health was truly, truly historic. But as we know, that event was only the beginning of the work that needed to be done. In the months that have followed, the administration has been working strategically and again tirelessly to implement the national strategy to end hunger, reduce diet-related diseases, and increase physical activity among all Americans. For the White House to shine a spotlight on issues many of us in this room have been working on for decades means more to me personally than I can properly articulate. It makes me proud to be an American, which is not something I could always say. Throughout the years, I've spent a lot of time protesting particular administrations who will remain nameless. But now we have this administration that works across aisles and cares about our food and agriculture systems and the ways that they contribute to good health and livelihoods. So today, we are all here together in support of these efforts and to identify new opportunities to advance the integration of nutrition and health and to improve food and nutrition security, issues that represent 2 of the 5 pillars outlined in the White House National Strategy. We'll be documenting what happens here today, including the panels that you'll see on stage and in your breakout sessions. That means that the role each of you play today is absolutely critical. No one can sit this one out. We will begin in just a moment, but a few words about the afternoon. Today's event would not have been possible without the generous support of Stop and Shop, and I want to give a big thanks to Stephen Jennings from Whole Del Hayes, USA. I hope those of you who have been here for a few minutes have had a chance to enjoy the delicious lunch spread provided by Farmer's Fridge, who, since their business started, have supported Food Tank. And I want to thank also Traditional Medicinals for supporting today's summit. Again, without all of them, we wouldn't be here today. This afternoon, you're going to hear from more than 40 speakers who represent the public and private sectors, as well as the nonprofit and philanthropic communities. We have chefs, professors, doctors, business leaders, public health advocates, scientists, elected officials, and researchers, along with some of the leading food and agriculture journalists in the Boston area. I promise you that today we will end on time no matter what. The conversations will be very dynamic and fast-paced. I have to ask, if I cut a panel short, no matter how interesting or engaging it is, that you forgive me. There will be time for networking during the reception, which I hope you all stay at. Please feel free to leave the room for snacks or beverages or for bio breaks or for fresh air. We want you to be as comfortable as possible. And please, again, make sure you stick around for the reception where you'll have a chance to speak with your fellow attendees and the panelists. And everything you see today will be available on Food Tank's YouTube channel. Before I introduce our next speaker, I want to ask that you share your favorite moments, or maybe your least favorite moments, from today's conversation using the hashtag #FoodTank across all social media platforms. We will do our best to reshare your posts and respond to your comments throughout the day. And now let me welcome someone I have admired for a very long time. She has devoted her life and career to the issues that we'll be talking about today and has set an example of what both an academic and an advocate can look like. Dr. Christina Economos, the newly named dean for the Friedman School at Tufts University, it is my sincere honor to welcome her to the stage.
Thank you. Welcome, everyone. On behalf of the Friedman School of Nutrition, Science, and Policy, I'm so glad to see a full room here today. And let me just pause and say, you are exactly where you're supposed to be. This is a group of enthusiastic and dedicated people who are thirsty for more. They want to really understand the issue, and I also know want to leave today and have an impact. So I'm so glad that you are all here today to join us. The second thing I want to say is the Friedman School is a place that's very welcoming, and we are so glad that you chose to spend the afternoon with us today, and we hope that you'll come back. We hold a lot of different events and conversations, and it's a place that we feel is really important, that everyone feels they have a space and a part of the conversation, and we want you to feel like this is your home. So as Danny said, she feels like she's coming home. For some of you, I hope you feel like you walked into our home for the first time, that you'll come back and join us in the future. So we're so delighted to be hosting today, and particularly as Danny Nirenberg, as you already heard, co-founder and president of Food Tank, along with Bernie, her co-founder. She's an alumna of the Friedman School, and we couldn't be more proud to have her running this organization and joining us today. And I'm also proud to say I'm an alumna of the Friedman School. So we are taking over today. But one thing we do here at the Friedman School is put people out into the world to make a difference. And so you're seeing examples today throughout the course of the day of people who are doing that. So for those of you who are not familiar with the Friedman School, we're the only standalone School of Nutrition, Science, and Policy. We're 40 years young, and we have a powerful and needed impact on nutrition and health worldwide. We conduct research from cell to society, we train future leaders, and I think most important to many of us, we reach deep into communities and co-create innovative and equitable food and nutrition solutions across the globe. So you all know that unhealthy food is now the leading cause of poor health in the United States and worldwide, causing enormous burdens to malnutrition, obesity, and other preventable diseases. But we also care a lot about what our society is facing in terms of stark racial, ethnic, and socioeconomic disparities with respect to access to high-quality food. And inequities across the food system is an area that we dedicate a lot of our research to at the Friedman School, and you'll hear more about that today. So the 2022 White House Conference on Hunger, Nutrition, and Health was an incredibly important milestone in the field of nutrition, and convenings like these are what's keeping the momentum going and the hope alive as we all strive to implement the Biden-Harris administration's national strategy on hunger, nutrition, and health. So I just want to take a moment to acknowledge my colleague, Dariush Mozaffarian, and his leadership in this space. And I want to thank him for all that he's done and all that he will do to advance policy across the U.S. Thank you, Dari. And I just want to close by saying today's event and the conversations and the engagement that will occur in this room and with all of you online and after we all leave is exactly what we're proud to support at the Friedman School and take part in. So thank you for being here today. Enjoy the event, and I look forward to talking with many of you.
Thank you so much, Dr. Economos. It's such a pleasure to see you and to have you here. And congratulations to you, too. Bernard, could you come help me? Thanks. Oh, I got it. Okay. Sorry. I'm a little broken right now. You'll get a chance to hear from Dr. Economos later in the program, and you won't want to miss it, so please stay here. It is now my pleasure to welcome to the stage Kat Okar, the Special Assistant to the President for Community Public Health and Disparities in the White House. She and I will have a really fun fireside chat about the Biden-Harris administration's national strategy on hunger, nutrition, and health. She's one of my very favorite people, and I'm so glad I've had this chance to work with her. So please welcome Kat to the stage. So, Kat, thanks so much for being here.
Thank you so much for having me. Oh, I feel like Britney Spears with this.
I know, right?
Yes.
Until it falls off.
It's until it falls off. That doesn't happen to Britney.
So I get to interrogate you.
Great.
And
That
I'm
sounds
really, really
fun.
excited about it. So I do want to start by talking about the national strategy and why was it so important for this strategy to, and the conference to happen last fall? Why was that such a pivotal time?
So many reasons. First of all, hi everyone. It's so good to be here. Hi to those of you online as well. And thank you so much, Danny, and to you and your team. I mean, for folks in this room, they are masterful. It is just incredible. Your team is incredible, and huge thanks to the Food Tank team and Tufts for having us all here today. And as the dean mentioned, keeping the momentum going, which is so huge. So the reason we had the conference was several reasons. One, the last conference was 50 years ago, and at the time, we were facing huge, vastly significant rates of hunger. And from that conference, so much came out of it. Things like SNAP and WIC and school meals, improvements to those programs as well. And so 50 years later, we're still dealing with hunger. But now we have this whole other set of issues in terms of chronic disease, in terms of diet-related disease. And so the president was very much focused on, look, we need to end hunger, but we also need to really reduce diet-related disease, because as intersectional as these issues are, they are taking such a burden on this country, such a toll on this country, and that's unacceptable. I mean, the fact that we're looking at rates of 1 in 10 households that are food insecure, 2/3 of American adults that are overweight or obese, 1 in 3 children that are overweight or obese, diabetes numbers ticking up, hypertension numbers ticking up. And so there are significant issues here that I think are not only leading to poor health outcomes, but also decreasing workforce productivity, having an impact on how much money we spend on healthcare every year, and that affects us all, as well as things like military readiness. And so really the issues were so apparent and the numbers were so sobering, but also the opportunity was so great. I think we very much saw that if we have this conference, the energy and the momentum that can come from it is unparalleled. And we're really at a truly exciting time. Hard to believe we're more than 6 months after the conference, but really I think we're at such an important moment to continue to make change and make progress from that strategy and that conference.
Absolutely, and the issues that you outlined, the problems that you outlined are truly unacceptable, but as you also said, the opportunities are so great, and that's part of the reason we're here today, to continue those opportunities, to find those unusual collaborations that will really make things happen. For me personally, I would love to hear a little bit more about how the 5 pillars were sort of constructed.
Sure.
I feel like there were late nights, probably eating not so healthy food to come up with these pillars.
Yes. Yeah, so I think it was a lot of late nights and early mornings. But I will say, and I think so many of you submitted comments, and we read literally every single one of them. And so much of the feedback that we got from external stakeholders, like all of those in this room, virtually, really fed into kind of how we built those out. I think we knew what the issues were, but thinking about everything from food access, food affordability, local food procurement, all the way to why does research play a role, all came through in the comments that we got and the listening sessions that we did, and the conversations that we had with people with lived experience, and thinking about what people who deal with hunger day in and day out, or people who deal with diet-related disease have to face. And so that's really kind of how we thought about building the pillars, was a lot of the feedback that came in, what the evidence shows certainly, and kind of what those with lived experience were telling us were some of the barriers to leading a healthier life.
And it was really great that those folks with lived experience were part of the conference, that they were able to engage directly with the White House and with all of us. That's really extraordinary.
Well, I think it's essential, and I think it can be so easy to get lost in the work that we do day in and day out because nobody has enough time in the day, nobody has enough hours or computers to do enough of the work, but we're doing this to help people. And if we're not grounding ourselves in what is actually happening in people's lives, then we're not doing as well as we could be. And so that was really fundamental to us to do and to really highlight that perspective at the conference, but also inform our strategy as well.
Absolutely. Thank you for that. I'm interested in hearing from you what progress you've made over these last 6 months.
Yeah, so much. And so, we've done a number of things. I mean, the fact that we got summer EBT to be a permanent program is huge. And we don't talk about it enough, and I think it is a huge focus. But we're also saying, I know we're talking so much about food as medicine today. We've approved a number of demonstrations from Massachusetts to Oregon to Arizona to Arkansas and Medicaid that are testing some of these strategies to improve nutrition security, to improve nutrition counseling in our Medicaid population. Because we know, as Dean Economo said, as you said, Danny, disparities persist year after year, and not only in Medicaid populations and communities of color, in our veterans populations, in the military population, and rural populations. And so we're very much trying to be very deliberate about having this be, as we continue to say, whole of government. And so what we mean by that, in addition to summer EBT, in addition to some of the CMS waivers, we're thinking about this across 20 federal agencies. Some people don't even realize that there are 20 federal agencies, but there are. And so, thinking about HHS, thinking about USDA, but, our Veterans Affairs, the Department of VA, just launched a produce prescription program in partnership with Rockefeller. So they're doing a pilot in Houston and Salt Lake City. The Indian Health Service is also doing a produce prescription program. The Department of Defense and VA have committed to screening everybody that comes through the doors for food insecurity. And so if you think about the potential here, the vision of if everybody that comes through the healthcare system is screened for food insecurity, if every provider is armed with the tools to screen and refer, if there are enough dietitians in the world to be able to offer those services, the opportunities are endless and the need is tremendous. And so that's just kind of a little bit of a taste of what we've done. But I'll also say, this past March, we launched what we are calling the White House Challenge to End Hunger and Build Healthy Communities. And this is really our attempt to galvanize the second tranche of commitments, because during around the conference, we galvanized $8 billion worth, which is incredible. It's a lot, but it's not enough. If we're actually going to end hunger, if we're actually going to reduce diet-related disease, we need way more. And that is where you all come in. And it doesn't matter if you're a small business, small restaurant, or a major corporation. As you mentioned, everybody has a role to play. And so would really encourage you all to think about what that could look like. We're really excited to encourage all of you to think about making a commitment. We're hoping to have an event in September, October to highlight what those commitments are and really tout the incredible work that is happening and will still happen and want to work with you. And so if you're interested, I would encourage you to go to whitehouse.gov/hungerhealthconference, whitehouse.gov/hungerhealthconference, submit an interest form, and let's have a conversation. We are on every single call with our partner, the CDC Foundation, and would love to talk more about what more we can do, because as I mentioned, the potential is so huge, and it's such an exciting time.
It's such an exciting time, and I have to commend Kat and all of her colleagues again. They will be on every call. They will work tirelessly. She's not just making this up. I know from experience, so please reach out to her. I'm wondering, Kat, what are you looking forward to most from what we'll hear today?
Well, it's so amazing to see such excitement in the room and interest in food as medicine. As a public health nerd, this is heaven to me. But I think what I'm most excited about seeing and hearing about is the potential, is what everyone from a medical school or a public health school or a dental school to a city to a major corporation like Stop and Shop and Google, who I know are here, can bring and are already doing, but are thinking about kind of what that 2.0 looks like. Because as I mentioned, we have to make this a whole of society approach. And I really think that, and hopefully what comes through today is that we're building a movement. The time is now. I think finally, for those in this room, we're almost like an echo chamber. We get it, but I feel like it's finally coming across beyond just this room, into the healthcare system, into communities, into states and governments who recognize why food as medicine can transform lives. And so I think that's what I'm most excited about hearing is the potential and the opportunity and the excitement.
Me too, and we really are building a movement that will spread far beyond Tufts and far beyond the White House. So thank you again, Kat. What a pleasure to work with you.
It's so amazing to work with you. Just so excited to be here and excited for the day. And if I can do anything to help any of you virtually as well, please reach out to us. We are, as Danny said, at the ready on email 24/7 a day.
Kat will be here all day.
Yes, I will be here all day. So look forward to chatting and meeting many of you.
Please give her a round of applause, everyone. Thank you, Kat.
Yeah, okay, thank you.
I now get the pleasure of introducing another mentor, friend, and someone who should definitely run for office, although he'll keep getting appointed to other offices by the government, I'm sure, and that is Dr. Dariush Mazafarian, who helped to provide a bit more context for our conversations around the food as medicine movement. A huge congrats to Dari on his new role at Tufts on food as medicine. He's creating a new cross-university, cross-national collaborative to transform healthcare, a collaborative founded on the Tufts University's traditions of innovation and commitment to public impact. So I want to thank Dari for devoting his life to service. He truly is a hero. Please welcome him to the stage.
Thank you, Danny. So it's such a pleasure to be here. And I think, do I have control? There we go. Thank you. So it's such a pleasure to be here and to see so many new friends, closer old friends that we've had for a long time and sort of allies in this fight. And I want to echo the thanks, and there's been a lot of thanks today, but I really think it's important that we sort of acknowledge all the work that is going into this movement in our country around advancing nutrition, ending hunger, and reducing diet-related chronic diseases. I'm a doctor, I'm a physician, I've been in healthcare my whole career, and there are very few things that I can say the U.S. is sort of leading the way in healthcare system transformation around the world. But food as medicine is truly, truly an American invention and is really leading the way. And we've spread it now into Australia. I had a call with someone in the UK government. This is really an incredible movement. So I really want to thank really important collaborators and leaders who made this happen. So thanks to the Biden-Harris administration for hosting the White House conference. That was an incredibly important moment. And to Ambassador Susan Rice and the Domestic Policy Council, who really made this one of her major priorities, and to her team in the White House, so Katherine Oker and Kellyanne Blazek and Will McEntee and Laura Carroll, who's now back at FDA. They just did an enormous amount of work. Also to the bipartisan support from Congress, particularly Congressman Jim McGovern, who's been talking about this for over a decade. He's really the single most tireless champion around hunger in Congress, but also the late Congresswoman Jackie Walorski, his Republican colleague, Senator Booker, a Democrat, and Senator Braun, a Republican in the Senate. There was a lot of support from them for the White House conference. And today we're talking to leaders on both sides of the aisle in Congress, and there's a lot of support for food as medicine. So I think this is a really exciting area. And thank you to Danny and Bernie and Food Tank for co-hosting this today with us with the White House. So a little bit of framing, and it's just important to step back, and many of you know these statistics, have heard me or others say them, but it's just so shocking how ill we are. It's incredibly shocking how ill we are as a nation, with much of it due to food, and most of it happening in my lifetime, in my adult lifetime. I graduated from college in 1991. We did not have an obesity and diabetes epidemic in this country in 1991. In my adult lifetime, this has happened. More U.S. adults are ill than are healthy. 1 in 2 adults have diabetes or prediabetes. 3 in 4 have overweight or obesity. And if you combine that with blood pressure and cholesterol levels, only 1 in 15 are metabolically healthy. This starts in kids, among teenagers. 1 in 4 teenagers have prediabetes. That's not okay. 1 in 4 have overweight or obesity. 1 in 6 have fatty liver disease. As a nation, we are failing nutrition. Out of 100, our average score on adherence to a healthy diet is a 58 out of 100. And this is true across age, sex, income, racial, ethnic groups. And it's worst at ages 5 to 18. We're failing the kids more than anyone else. Diet quality is worse among ages 5 to 18. And if you actually do careful quantitative analyses, this is unbelievable how much death and destruction this is causing. Poor nutrition directly kills 10,000 Americans every week. Directly causes 21,000 new cases of diabetes every week. This isn't the total cardiovascular disease burden or diabetes burden. This is that's directly attributable to poor nutrition, and 45% of all cardiometabolic deaths. My clicker is not always working. There we go. And there's a lot that goes beyond this. And I think COVID-19 is one of the reasons we're here, because this shined a light on how sick we are as a nation, with diabetes, hypertension, and obesity being the top risk factors for poor outcomes from COVID-19. And from our analysis, we've estimated that 750,000 people died that didn't have to die if we had good metabolic health. They would not have died. COVID would not have been as severe. And if you put together the healthcare costs and the lost productivity costs, just those two costs, it's estimated $1.1 trillion a year is being lost by our economy. $1.1 trillion. The current budget battle between the House and the Senate is about $100 billion a year. If we just took 10% of the healthcare costs of diet out of the healthcare system, we would pay for all of the budget battles. And now there's also an incredible positive here. There's a potential to lock business innovation. We have Secretary Dan Glickman here, who talks about this all the time. The food sector, from ag to retailers to supermarkets to ag tech to restaurants, this is a major part of our economy, and we don't think about this as a major part of our economy. 1 in 10 jobs are directly supported by food and ag, let alone all the indirect support. It contributes to about $1 trillion in positive economic output. Exports, it's the #1 source of new jobs in small businesses in minority and ethnic communities are companies in the food sector. This is a source for economic empowerment for our minority communities. Consumers are now demanding healthier foods, which is a business opportunity, and there's a rapid growth of ESG investing, which is also a business opportunity. So how do we shift this 20th century food system that we have in the 21st century? We have a system that's been built not by industry setting out to make us sick and fool us all and addict us on food, but we have a food system that was built very specifically for goals of the 20th century. What were the two big goals of the 20th century? Getting vitamins to people, because that was the science of the 1930s and 1940s and 1950s, was vitamin deficiency diseases, which were very common in the United States, and getting calories to people, because the population was exploding from about 1.6 billion to 6 billion in the last century. So the main goals of the last century for food were vitamins and calories, and we were successful. We created monocropping of crops to be able to feed a massively growing population. We created highly processed, shelf-stable, vitamin-enriched foods, which have largely eliminated vitamin deficiency diseases. We created this food system consciously, and it met the goals and was successful for those goals of the 20th century. But now we have this 20th century food system with 21st century problems that I've just outlined. So this is a very simple roadmap. We've created the modern food system in about 50 years. We started working on this around 1960, 1970. We were done by 2000. It was a very conscious effort, and it happened very quickly. And how did it happen? It happened through a combination of, I have to click 2 or 3 times, sorry everyone. It happened through a combination of scientific advances, government action, and private sector innovation. This was the roadmap to create the modern food system that we have. Science was advancing in the last century around vitamins and calories and the population explosion. Government took notice and said we have to have policies and actions and investments like the Green Revolution in Mexico and India and Pakistan and elsewhere, and private sector innovation that drove the incredible successes of getting food and vitamins to people. This is the roadmap. And so we need to take the science we have now, work with government, and bring in the private sector, which also includes civil society and nonprofits and of course, all the advocacy organizations, and fix the food system. And I think we can do this in 10 or 20 years if we put our minds to it. So it's not simple. There's not one answer, but there's also not 1,000 things we need to do. There's about 30 or 40 things we could do to dramatically shift the food system in the United States. And these are kind of the domains of actions that we need to focus on. And this is from a task force report that we put out in advance of the White House conference. And much of this is reflected in the new national strategy. Now, food as medicine, I think, is particularly exciting because it finally brings healthcare into the conversation. This is almost $1 in $5 that we spend in our entire economy. $1 in $5 that goes through everybody's pockets goes to healthcare. And so we need to take that and leverage it for food as medicine. First, let's level set on what we're talking about. And I think today, actually, probably all of these definitions of food as medicine will be used. So I've heard food as medicine used in broad ways. There's no single definition that's out there. But these are sort of three broad ways that I hear food as medicine most commonly used. The first is just the very, very broad concept that food is foundational to health. If we want to think about health, we have to think about food. And people who use that definition almost don't even like the definition of food as medicine, the term, because they think it medicalizes food. And they almost prefer the term food as health. That's the very broad concept. The second, more specific concept is to think about food as medicine. So the hundreds of thousands of bioactive compounds that are in foods like cocoa and green tea and blueberries and coffee and many, many other natural plant compounds, these natural bioactive compounds, how can we identify them, leverage them, personalize them to treat disease? There's a whole world of science that's advancing this. But the third definition is the one that I typically mean when I use the term food as medicine. I think it's the one that's the most commonly used, is food-based nutrition interventions within healthcare system to treat or prevent disease. And I start with treat because very often when I talk to policy leaders or physicians or even members of the public, they say, yeah, we need to think about prevention, and an ounce of prevention is worth a pound of cure, and nutrition. All that's true, but here we're also talking about treatment of disease. We're talking about taking people with cancer, with diabetes, with heart disease, with hypertension, with heart failure, with significant diseases, and treating them with food. So it's not just prevention. I think there's two core concepts which make me think that food as medicine is so powerful and why I'm so excited about it. First, it addresses both food security and nutrition security. It addresses getting food to people who can't even know where their next meal is coming from, and making it nourishing food that helps their well-being and their body and soul. And so there's very few things that can address food and nutrition security jointly. And secondly, it's centered in health equity, and that's so important in healthcare. Whenever we have a new innovation in healthcare, a new drug, a new device, a new screening tool, who does it go to? It goes to the people that probably need it the least. And the people who need it the most vulnerable populations are left behind. This is seen again and again and again. And so healthcare innovations tend to widen health disparities, unfortunately. And here, we actually have a healthcare innovation that is directly targeting the most vulnerable populations among us and can actually improve health equity. So the way I think about food as medicine, this is a pyramid that we constructed with folks from the Harvard Law School, the Food as Medicine Coalition, and leaders at the Centers for Disease Control and Prevention. And so the way we think about this is a spectrum or a pyramid of interventions, with interventions at the top being for those patients who are extremely ill, all the way down to general population level healthy foods policies and programs. The three first bars are actual interventions that doctors can prescribe, or nurses can prescribe, or social workers can prescribe: medically tailored meals, medically tailored groceries, and produce prescription programs. Then there's using the federal nutrition programs like SNAP and WIC and school meals and meals for the elderly to advance nutrition security and food security linked to healthcare, and then finally population level programs. We don't have time to go into all of these now, but I think in the discussion we will talk about all of these. These are really, really exciting innovations that are happening right now in healthcare. And the momentum is incredible. This is just a list that I came up with just in the last few weeks of just all the things that are going on just in the last year around food as medicine, from the White House conference to the national strategy, to the state Medicaid waivers now approved or pending in 9 states to test food in healthcare, to what's going on in Medicare, advantage organizations, private healthcare organizations like Kaiser and Geisinger and Elevance and others, the VA and Indian Health Service pilots, a potential Medicare pilot. I think we're going to see a bill drop soon in Congress about a Medicare pilot on produce prescriptions. The USDA GusNIP produce prescription program. There are leaders here in the room who originally got us FINI, like Orrin Hesterman, Michelle Nishan, others who've worked on this. This needs to be expanded. CDC programs. The FDA is talking about human nutrition and revamping its program. The accreditation organizations for residencies and medical schools are talking about making nutrition education finally required for doctors and other healthcare professionals. The NIH is going to be investing in this. Rockefeller and the AHA are investing in this. And there's many, many nonprofit and private sector implementers who are actually actively scaling up food as medicine. This is an incredibly, incredibly exciting time. None of this was happening 5 years ago. It's incredible, and this is ramping up truly exponentially, and I think we're just at the very start. This is just a chart of the various Medicaid 1115 waivers, just to show you the red waivers that have been approved don't really have anything around nutrition. The yellow ones all have at least nutrition education and counseling and connections to federal nutrition programs. And the green are the more holistic, complete food as medicine programs. Incredible momentum happening here. Sorry, I think the clicker, sometimes I have to triple, quadruple click. Can someone forward for me in the control booth? Doesn't seem to be forwarding. Thank you. So we've just published, together with Hillary Seligman and colleagues, if you could go back, a NOPRIN handbook on food as medicine for healthcare professionals. So if anyone is interested in that, I can send you the link. That went by quickly. And then also talking about new commitments, I'm going to be working with the university, and hopefully we're going to be able to make a formal commitment in August to the White House for a major new investment at Tufts in food as medicine to really create a cross-university initiative that brings together what's happening already in food as medicine across the several schools of the university, works with other hospitals in the Boston area and nationally, works with nonprofit partners, and really elevates food as medicine. Next slide. We'll go forward to that. Next slide, please. So I think this is a really exciting time. I'm going all in. This is going to be my full-time job to be leading this new food as medicine initiative now at Tufts. And so anyone who's interested in food as medicine and working with us and partnering with us, please get a hold of me. And thank you so much for being here.
Thank you so much. More applause for Dr. Mazafarian, please. And a big congratulations to him on his new endeavor, which is so important. I always feel very inspired and hopeful after Dari talks, because that list of what's going on around food as medicine is so exciting. And I think, we're seeing so much momentum now, and that's more than I could ask for. So before we continue, I want to take a moment to encourage everyone who hasn't already subscribed to Food Tank's podcast, Food Talk with Danny Nierenberg, to do that right now. You'll be able to find the conversations that you're hearing today starting next week on the podcast as well. It's a top 100 podcast. I personally think it should be a top 10 podcast. But Tufts gave me a lot of confidence in myself, so thanks to the Friedman School for that. To do that, to get it into the top 10, we need Apple's algorithm to be algorithming, okay? So I have to ask everyone, I will give you a giveaway to do this. You'll get this exciting book, Dreaming in Spice by Chef Harry Pulapaka. It's a sinfully vegetarian odyssey. If you go right now, take out your phones. This is the only time I'll let you do that. I'll just watch you very closely until everyone takes out their phones. I can stand here forever, broken foot or not. So if you take out your phones, go to the podcast app, find Food Talk with Danny Nierenberg. If you subscribe, rate, and review, you can just subscribe, actually. You don't have to do all that. You will receive a free signed copy of this really beautiful book, again, by Chef Harry Pulapaka, Dreaming in Spice. It has more than 250 recipes on plant-based cooking. I wrote the foreword. What more can I tell you? I think it's a great book. And once you do that, please raise your hand, and one of our Food Tank volunteers will come and make sure to give you a book. Again, I'll wait here awkwardly. Thank you. Yay, yay. Round of applause. Okay, thank you, everyone. And a big thanks to Chef Harry Pulapaka for donating his book to us. While this is all happening, please join me in welcoming our first panel of the day as we look at the opportunities to expand nutrition education for healthcare providers, which is so, so important. To explore this topic, we're joined by Dr. Stephen Devries, the Executive Director at the Gaples Institute of Nutrition and Lifestyle Education and an Adjunct Associate Professor of Nutrition at the Harvard T.H. Chan School of Public Health. We also have Kimberly Dong, an Associate Professor of Public Health and Community Medicine at Tufts University School of Medicine. We have Dr. Ashley Longacre, an Assistant Professor of Practice with the Connell School of Nursing at Boston College. Dr. Shirley Chow, the former co-chair of the Massachusetts Commission of Malnutrition Prevention Among Older Adults and the principal at Food Policy Insights. And we have our moderator, Sarah Blackburn, the publisher and editor-in-chief for Edible Boston. Please give them a round of applause as they come to the stage.
Hi, everybody. Hi, everybody. We're panel number one. Thank you to the Tufts School for inviting all of us to be here. I know we're all really honored to be on this panel, but I'm going to jump right into it because I know we have a wonderful long day of programming. You all have dedicated your careers to educating future healthcare professionals. You teach the future nurses, doctors, dietitians, who are really at the front lines of medicine in this country, the most important interface for the patient population. So why do you think nutrition isn't yet part of the curriculum universally in medical schools and nutrition schools, nursing schools, excuse me? Even now in 2023, when with all that we know about how food is medicine or food is health, as Devries just said, you can start first, Steve.
Sure. Well, I think it's the culture of medical education. It really emphasizes the role of acute care, because just think, these physicians are being trained generally in hospital settings, and it emphasizes the role of pharmaceuticals over other treatments. And if you ask medical educators why they're not spending more time on nutrition, they say, we don't have the time. But think about this, and the data is really clear on this point, that if you look at the top risk factors responsible for death in the United States, 17 top risk factors examined, number one is poor quality diet. So let me ask you, if nutrition in a meaningful way doesn't make the cut, why not? What could be more important?
I think that's a perfect response to this, actually. Our medical system is, of course, very treatment focused, and I come from things with a bit of a public health lens, and so we think about prevention and intervention all of the time. So if we need to kind of turn the conversation to nutrition as this preventive or vehicle for intervention, and that would certainly make an impact there. I have some hypotheses about this. I'm not sure if any of them are correct, but nutrition is a relatively young science compared to other fields. First vitamin was isolated only in the 1900s, and so that's not terribly long ago. That's just a century ago. It's also very personal and very cultural, and so I think there's a little bit of hesitation to really get in the weeds with something that is so inherent to who we are as people.
Kim?
Yes, I echo all that Stephen and Ashley have said. I think in addition to the board exams for medical schools and nursing schools, they don't prioritize nutrition. The case studies don't include nutrition. And so I think, trying to change the exams to be more current with what we are seeing in the healthcare field is necessary as well.
I come from a different angle. So the way I look, I do agree with everybody saying. I think it's all the medical society understand is nutrition can empower them to provide more comprehensive care. And nutrition is not only a diet guidance. Nutrition involves in many things, the food insecurity, cultural competency, and other environment conditions. So I think if we realize we all agree with that, the teamwork to include the nutrition is very important.
Okay, so we've identified that. But so Steve, in your experience, what is the current state of nutrition education among health professionals, and what progress has been made, and where do you see this going, and how could it go further?
Well, the current state is kind of poor.
Yeah.
And where it is in medical school, on average, about 19 hours spread out over 4 years. A lot of that is related to biochemistry, which is a very important topic, but it's not exactly, in typical way, directly relevant to patient care. And the lack of prioritization on nutrition has not been lost to the medical students, because get this, in a survey of incoming medical students, asking them about how relevant they felt the role of nutrition and its connection to health was, those incoming students felt that nutrition was more important than outgoing medical students survey did. So that tells you a lot about where things stand. And unfortunately, in graduate medical education, sometimes things even go downhill from there. Because for many specialties, key ones like internal medicine, pediatrics, cardiology, my field, there are 0 nutrition competencies currently set. 0. So with all of that, now there are some really exciting, innovative programs, a lot with culinary medicine going on, and they need to be enhanced because many of them are now electives. Many of them are supported by philanthropy, and there's nothing wrong with that, but it's not exactly a sustaining model in every case. But with that, I believe there's a lot of room for optimism, and I believe this last year has been the most optimistic of all. Why? It began just over a year ago. The U.S. House of Representatives had adopted a resolution that was introduced by Congressman McGovern and Burgess. This was a bipartisan support. I mean, you can't get bipartisan support for like the benefits of motherhood. I don't think that would cut it. But this was for nutrition education, how important it was for doctors. Then came in September the White House Nutrition Conference that is part of the strategy. Nutrition education for health professionals was highlighted, very importantly. And for that, we can, to a large extent, thank Kat Okar. I don't know if she's in the room, but she has done a lot to move this forward, and I think deserves a big round of applause for that. Awesome. And then, as Daria had referred to, the ACGME, the accreditation group for physicians, had launched their first ever nutrition education summit just 3 months ago in Chicago. And so we're really hopeful that there are going to be some great changes there. And I have to say that this area has affected me personally. I had a very busy preventive cardiology practice with a 9-month wait list, and actually felt like I could make a bigger impact in that area by becoming director of the nonprofit I direct, the Gaples Institute. And I'm very proud to say that the Gaples Institute nutrition course that's been developed is now required in 7 medical schools. It's required, not elective, and 97% of the students who take the course say it will change their practice. And can I tell you one of the most rewarding things and what really justified this career transition is the fact that every single day I get comments from medical students saying for the first time they're able to actually help their patients in ways they couldn't do before, ways they wanted to but didn't have the training. And the nutrition training actually helps their own self-care, something which really requires a lot of attention as the burnout rate among physicians is really high. So I wanted to actually think about this, make an offer to all of you, and this is a real offer. If you're ever having a bad day, write to me. Seriously, email me, and I will send you one of the comments that I receive. I'll take the name off, so you won't know who it's from, but really, it makes it just is so gratifying to get these comments. You'll love to get them too.
Well, I hope you will have his email. That'll be important to hold on to. Kim, so you teach here at Tufts, and this link between nutrition and health has been important in your teaching here at Tufts for a really long time and been underscored for students. It's been a priority. So can you explain why this approach is important here as opposed to maybe other places, and what does that look like in practice?
Thank you. I feel really fortunate to be here, faculty at Tufts. I teach the nutrition course for our medical students. And this medical course, not that I've been teaching it for a few years, but it's been embedded in the medical school curriculum for decades, which is really, I think, at the forefront. But I think us being here in the health sciences campus with the School of Nutrition, the School of Medicine, the School of Dental Medicine, nutrition has really been embedded into the curriculum for all of those programs. So all of our healthcare professional students are receiving that information. Our physician assistants students are also getting a nutrition course in their curriculum. And I just launched a community health worker training program where nutrition is also embedded in that curriculum. So I think, we're so poised to be able to do that here and to be the leaders in this. I think that, it's been really great to be a part of it. And I think just dovetailing off of what Stephen was mentioning, it's not just talking about the nutrients and the biochemistry. It's important for our medical students or healthcare professionals, but it's also thinking about the food as medicine approach and knowing that this impacts all of our patients. And what I say to my medical students is, this is not necessarily going to be on your board exam. So I know that you may not sort of be at the forefront because you're studying for that exam right now. But I guarantee you, nutrition, diet, all of this is going to come up with at least a majority of your patients. This is at the heart of what they care about. This is what they're dealing with on a day-to-day. So having that conversation is going to show to them that you care about them, and it's going to continue to build that rapport and trust. And I think that that's true, right?
Yeah. And Shirley, so as a dietitian, can you talk about the importance and effectiveness of malnutrition screenings, especially for older Americans, which has been your expertise, and doing that as an early intervention before someone has diagnosed?
Malnutrition with elderly actually is a very serious issue. In the community, sometimes you wouldn't even know this person is malnutrition. And it could be undernutrition, could be overnutrition, could be obesity, or be frail. The older people, they deal with a lot of issues, the loneliness, isolation, and food insecurity. It's a lot of issues. So the nutrition screening in the early stage in the community and in the hospital can help the recovery of disease, but also the prevention, that can help them regain the quality life. I think that's one thing we all agree, is some simple intervention can change a person's life. So that it go back again. You have to recognize the importance of nutrition as a primary determinator for health.
Well, so this leads right into my next question to Ashley about nurses, who generally are going to be the first people on the front lines with a patient. So what role can those nurses play in delivering healthcare information, nutrition-related information during a healthcare screening to their patients? And I know that's important in your teaching at BC, but are there other places that are working on that?
Sure, that's a great question. So nursing is the largest healthcare profession in the United States. There are over 4 million registered nurses. So if we're talking about sheer volume, sheer numbers, that is a sizable impact if every single one of those nurses had nutrition information that they could impart to their patients. But getting away from the numbers, I think generally nurses spend a bit more time with the patients than physicians get to, and so they get to know a little bit more about the patient history, the patient context, and so we would hope that they could provide accurate nutrition information that's relevant to the patient for their history, for their context. If it's something that rises to the level of some sort of nutrition intervention that's needed, something that is feasible for those patients, maybe tackling issues related to food access, food insecurity in some of those conversations and screenings that happen in primary care facilities. And in terms of places where nutrition education for nurses is really doing well, I want to highlight UPenn. They have an excellent series through their nursing school of majors and minors, again, embedded within the nursing school, and also graduate certificates for graduate nurses, nurse practitioners, et cetera. And so they've set up a really nice template for, I think, a lot of nursing schools to potentially follow and see where it leads.
Oh, that's great. All right, Steve, so what are the opportunities for interprofessional work and an approach to nutrition education and patient care? So how do you maybe get a doctor, a nurse, and a nutritionist together in that realm?
Yeah, that's a really great question because you won't find any bigger advocate for the role of physicians getting involved with the nutrition, but it's very clear. Physicians can't, won't, shouldn't do it all. This is a team approach that is absolutely needed. But the whole idea of nutrition education for physicians is to get them up to speed so they can be meaningful members of the team along with the dietitians, the nurses, the health coaches, the chefs, and everyone else. So, what's really interesting is that, I wanted to study this question and did a study that looked at physicians who got just a little bit extra nutrition education after their training, and it showed that those physicians were almost twice as likely to make referrals to nutrition and diet professionals. So the idea is we've got to get everyone up to speed so that everyone can make the maximal contribution, because doing anything, giving medications is not a habit that people generally will continue with, even that, but lifestyle changes can be challenging, and it takes the team that can make things happen. And with an interprofessional approach, the future for this area of food as medicine is awesome. Okay,
so Ashley, how do you operationalize that kind of nutrition education in nursing schools? And how do those courses fit into the existing curriculum? Do they have to replace something else? There's not all that much time in one's day. And are there, you already mentioned the other nursing schools, so that's, yeah.
Yeah, this is my big question too, frankly. I think we're all very happily, just with medical schools, nursing schools, they have competencies that are necessary to be taught for accreditation purposes, and we want that, right? We want everybody who comes out with a nursing degree or a medical degree to say, yes, they are insured to have these competencies, right? But nutrition, although in nursing programs, it's taught as, part of a patient's diagnosis or part of a patient's treatment plan or recovery, it's not the core focus. And so there isn't a specific set of guidelines for how nutrition needs to be taught in nursing schools and in nursing programs. As I mentioned, some folks or some programs, they offer nutrition electives, they offer nutrition majors and minors. Some schools take the approach of threading nutrition throughout other courses like pharmacology or health assessment. So it's always kind of there and embedded into other courses that have existed for a very long time. Is there a right way to go about doing this? I'm not entirely sure. I think we need more data. As the epidemiologist, I'm always going to say that, though. We need more data. What I will say, just kind of piggybacking off of things other folks have said, is there's certainly a recognition among our students that nutrition is imperative and important and cannot be divorced from good health. And so our lovely dean at BC School of Nursing, Kate Gregory, she was actually talking with a student at the end of the semester and asked, how did classes go? And the student brought up her pharmacology course, and usually pharm comes with a big, that's one of the hardest courses we have, of course. But the student just made this very innocent observation and said, we had 12 classes on traditional pharmacology, 3 in nutrition, and I think that if we'd had 12 classes in nutrition, we'd only need 3 in pharmacology. And
Brilliant.
And it's, again, such an innocent observation, but really astute and really profound. So there is recognition there from students. And again, I don't think that they're divorcing the nutrition and health concepts from one another, especially as conversations about social determinants of health are really starting to become more prominent in the clinical space.
Okay, so Shirley, then, what does it take to make sure that nutrition becomes just as important as any other subject in training future doctors and nurses?
Good question. I see a couple of areas. One is the dietitians, the nutrition experts should be sitting in the table to prepare the curriculum. I think that is the professional we are in, and that is very important. Who is teaching it? Also, I think maybe the dietitian, the nutrition experts to teach it. Another thing I see is adequate funding on some important initiative. Food is medicine, or nutrition screening in the community, or in the hospital setting. Those things will show more prevalence on the nutrition inadequacy. That will actually increase moved allocation to this direction. The last one I see is we need more campaign. Besides the nutrition experts, the dietitians, we need other healthcare professional. I would like to say is like Dean Musafarian. He is a cardiologist, I think I'm right, but his leadership and his advocacy in this field and made a significant difference, and that's where we are here today, have this conference. And seeing, I think I saw Dave Water earlier, is the rock is there. We are together move this rock. So I see it's a joint efforts and from different angle.
That's great. That's great. And Kim, this is slightly different, but as patients, people in general are bombarded every day with both positive information and disinformation online. What do you think that means for the importance of nutrition education for trainees as they're going to approach their work when they leave school and go into the field?
Yeah, great question. So, with social media, the TikToking and internet, all of that access, people have information at their fingertips. It's not always accurate information, and nutrition is also, part of that misinformation. So training our healthcare professionals, our physicians, our nurses, to work together with dietitians and other healthcare professionals to be able to be on the front lines to address what they're hearing in social media, and to dispel some of these myths is really important. And so I think that they'll have their work cut out and very necessary.
Yeah, I mean, I am a middle-aged woman with an Instagram account, and the number of things that are bombarded at me every day, and I think I know better, sort of, but it's hard. It's hard to know what's right. Okay, so in the final few minutes that we have left, I wanted to just ask you all to reflect on where you hope to see nutrition education in the next 5 to 10 years, and we'll start with you, Steve.
Sure. I can tell you by way of a story. I teach a class on physicians as change agents at the Harvard School of Public Health. And we have a final assignment for a nutrition-focused system change that the students want to propose. And this one is what crystallizes my vision of the future. This was an ER doc who said, patients come to the emergency room most often with acute manifestations of chronic disease. And if we could make urgent referrals to dietitians from the emergency room, wouldn't that prevent these patients from needing to come back? And I thought, wow, to look at the future in such a creative and big picture way, that's the kind of future that I envision, and that's the kind of future that I think we're all going to see.
Wow.
I'll echo Steve's thoughts on that. I think another thing that we talk about a lot is wanting our patient care to be thoughtful and deliberate and person-centered, and I think to really provide the best patient care, nutrition has to be part of that conversation. And so thinking about some of those immediate referrals, I think makes a lot of sense. Also, just having your health professionals know some of the resources that are available so that they can tell patients about, I'm thinking about, local organizations or food banks that they, might want to consider. Or if it's something like a patient comes in, screens for food insecurity, and they say, hey, we have somebody who can help you fill out a SNAP or a WIC application. That goes a long way. So I'm hopeful that in the future, healthcare professionals just have a better idea of the resources that abound and can pass that along to patients, in addition to the nutrition knowledge and information that they hopefully will have through curriculum.
Great. Echo all of those things, and just, again, this interdisciplinary nature that's important so that we can provide, frontline information from physicians and nurses, really detailed menu planning, et cetera, with dietitians, helping to find food resources in the community, also embedded with social workers, et cetera. But again, to emphasize that need to ensure that we're shifting that conversation to prevention as well. And so that if we can embed this in the curriculum and start to have our healthcare professionals even have this conversation about nutrition with the younger generation, so with pediatrics, or even just from day one, so that, healthy nutrition is sort of embedded from earlier on in life, I think is important.
And Shirley, you get the last word.
I got last word. I think I agree with everybody, the interdisciplinary approach and the interprofessional education, and I think we can bridge this knowledge gap between our professionals. And I definitely want to say, take advantage of the dietitian. They are fully trained, refer to them, and we work together as a team.
Thank you all. Thank you.
Thank you so much to all of the panelists. What a great conversation. I think it's clear that empowering health professionals will lead to empowered patients when we're talking about nutrition, and that's really what's so exciting. Before we turn to our next panel, we're going to share 2 videos. The first is from U.S. Congressmember Katherine Clark, who represents the 5th Congressional District in Massachusetts and serves as the minority whip in the U.S. House of Representatives. And then we'll hear from U.S. Senator Elizabeth Warren of Massachusetts. Sadly, they couldn't be with us today because Congress is in session, but they really wanted to send their remarks along for the event. And all of you who live here in Massachusetts as residents and as voters can be incredibly proud that nearly the entire Massachusetts U.S. congressional delegation, including both U.S. senators, contributed video remarks to today's event. Just one Congress member, Representative Richard Neal, did not send a video, so maybe you can call or write his office, or maybe just don't vote for him next time. I mean, it's up to you. While these videos are playing, I want to introduce our next panel that will explore the role of the private sector in advancing food as medicine. For this panel, we have Ashley Turner, the founder and CEO of FarmBox, Mike Wysong, the CEO of Care Pharmacies and chair of the National Association of Chain Drugstores. We have Taryn Farrelly, the Chief Science Officer of Traditional Medicinals. And unfortunately, your moderator, who is for this panel, Deborah First from the Boston Globe, has a very high fever today, so you're stuck with me. But it'll be a great panel. Thank you, everyone.
Good afternoon. On behalf of the House Democratic Caucus, thank you to Food Tank, the Friedman School, and all of today's participants for helping build a healthier, more just future. Last year's White House Conference on Hunger wasn't just a convening of our brightest minds and most ardent advocates. It was a rallying cry, a nationwide call to honor a basic truth, that access to healthy, nutritious food is a fundamental human right. Each of you has answered that call. Each of you is working to fulfill one of our society's most sacred responsibilities. And House Democrats are proud to be fighting alongside you. Over the last 2 years, we've taken historic action to keep families fed at the height of the pandemic, to bolster school meals for our kids, to stock America's food pantries. And in the face of right-wing attacks, we stood strong in defense of vital food assistance. Those are important steps, but we know they're not enough. 19 million Americans still live in food deserts. 34 million are food insecure, including 9 million children. That kind of moral failure requires an all-hands-on-deck response. We're counting on you to help guide our way forward, to develop innovative solutions, and to mobilize the grassroots movement we need to stamp out food insecurity once and for all. Because as President Kennedy once said, we have the capacity to eliminate hunger from the face of the earth. We need only the will. Thank you, and best wishes for a productive summit.
Hello to all my friends at Food Tank. I sure wish I could be with you in person, but I'm glad to have the opportunity to speak with you all at Tufts University today. Hunger and food insecurity continues to be a critical problem across the Commonwealth and across our nation. And that's why last year, the Biden-Harris administration issued us a challenge to end hunger and to increase healthy eating and physical activity by 2030. Integrating nutrition and health is a key part of achieving this goal. The food we eat can have a powerful effect on our well-being, including helping to better prevent, manage, and treat diet-related diseases. And that is why it is so important to empower health professionals to help their patients access healthy, affordable foods. The federal government has an important role to play in this. We should incorporate nutrition into federal health programs, including Medicare and Medicaid, in order to expand access to nutrition support and counseling. And we should continue to build the research foundation to better understand the link between nutrition and health, which will help us to identify and design new policies to meet the President's goals. So I want to thank Food Tank again for putting together this summit, and I encourage all of you to join me in thinking about how to tackle this challenge and how to make President Biden's health and nutrition goals a reality. Thank you.
I just want to acknowledge that Senator Warren said food tank at least twice. It gives me great joy. I want to welcome our panelists again. Thank you all for being here. This is going to be a great conversation. So Ashley, I get to sit at meetings with you quite a bit, I feel like, over the years. You always have great shoes on. But I want to start with you because I want to talk about the barriers to scaling produce prescription boxes. Why are there so many barriers to something that's so common sense to someone like me?
Yeah, thank you so much for having me, and that's a great question, and we have limited time today, and it's a really in-depth question, but I guess the best way for me to really sum it up is there's so many policy constraints right now. I think it also goes to many of our government agencies don't speak, right?
Right.
USDA does not speak with CMS, Center for Medicare and Medicaid, and there truly isn't a line item budget right now within healthcare for food outside of MLTSS population, which is like very, very chronically ill population that get, medically tailored meals delivered or meals post-discharge when you come out of the hospital. So when I started off in healthcare with FarmBox RX, we had to figure out how can we have this make sense, produce prescription, if you will, to a CFO of a health plan that knows that there isn't a budget within healthcare right now for food or produce prescriptions. And the way we've done that is by using the box of food as a tool to engage members in Medicare and Medicaid in doing other things that the government does pay the health plan to have done. Things like getting your mammogram, getting your flu shot, getting your diabetic eye exam. So truly, it was really revolutionary what my team did to get food as a line item budget without there being a budget. But we still have so much work to do. But we like to say at FarmBox RX, we don't need to hold the entire market. We just need to have a seat at the table that's going to allow other innovators to come in to help solve this massive problem we face.
Absolutely. That seat at the table is so vital for breaking down the silos that you first started talking about. So Mike, I want to turn to you, and obviously we have so many lessons that we are learning from the COVID-19 pandemic. I'm afraid that we're going to forget some of them, but we learned that, the role of pharmacies is so important. And I'm wondering how we can position pharmacies to treat not only symptoms, but address these sort of problems, be preventative, address problems before they become problems.
Yeah, I think, we tend to have a pretty short recollection on things. There were a couple things we learned from COVID, and being involved at both the federal and the state level and the rollout of that, one of the things that we learned from that is that the capabilities and capacity have to be there.
Yeah.
It was a really important issue that needed to be resolved. The people needed to mobilize around the uncertainty of that in a pretty unprecedented manner. Pharmacy, I think, has the infrastructure to address issues like that. I just think historically we look at the end of this and we're treating the symptoms of something, and I think that's a lens that is beginning to change as shareholders. And this meeting is really demonstrative of that. I mean, you look across what's here today, and I have to applaud all of you. There is a growing acknowledgement that we need to address the systemic issues that are driving a lot of these unfavorable results, which are driving up the unsustainable costs of healthcare here in the country. And so I think pharmacy could really play an important role in that, not just to treat the symptoms, but really begin to look at what people put in their bodies that are contributing to some of these health outcomes that are just not sustainable and compromising quality of life, particularly in underserved communities. And we see that a lot. We're a premier HIV provider in a lot of the underserved communities. And so we think there's a prominent role here for pharmacy to play and partner up with a lot of the nutritional companies to really address this problem in a really humane and honest way.
There's so much opportunity. I'm glad you mentioned humane. There's a way to do this in a way that really is human-centered and puts people's voices at the center of this. So Taryn, I'm wondering from you, since this is a panel focused on the private sector, and you're all sort of leading in this space, is too much emphasis being placed on the private sector or not enough?
I definitely think there could be more partnership. In terms of, I come from the dietary supplement industry. I've been there for 20 years. And we continue to look for ways to educate consumers on how well-researched ingredients, herbal medicine, other nutrients can have a significant impact on people's well-being, health and well-being. And the research, I think that the USDA, the NIH is doing great work to kind of look at a number of dietary components, but when you think about it, they're focused on maybe 150 or so dietary components, and in reality, when you consider that we're taking in like over 26,000 compounds from the diet, there's an opportunity to really understand on a much deeper level how other compounds, phytochemicals, phenolic compounds within the diet can have a significant impact. And that kind of research then, I think through partnership with the private sector can actually help inform consumers how they can have a more meaningful impact in their own diet. Yeah.
Thank you so much, Taryn. So Ashley, I want to go back to you, and I want to talk about the progress the private sector is making in this space around incorporating food as medicine as a concept into things that they do, but without the greenwashing isn't the right word here, but sort of health washing, without health washing it, with making it true and believable and important for consumers.
Well, I think if we take a look at, how much we've grown in the space over the last 3 years, right? So in 2020, the Center for Medicare and Medicaid allowed produce to be offered as a benefit to members in Medicare and Medicaid. And that was revolutionary in itself, right? They said, we're going to take a look at the whole person and what is making these individuals sick. And we've went from, in 2020, we had one single health plan that I had to beg and offered a kidney and to name my next child after them if they would allow me to give produce to their membership. And we now have 87 plans we work with. We're with 4 of the top 5 largest health insurers in the country. And so I think that speaks volumes as to where this is going to. If we even look outside of food, now the government is allowing things like pest control to be offered even as a benefit of what is that doing if pests are eating food in these members' home? So taking a look outside of, let's just treat with pharmacy, right? Let's just treat with medication. If you're type 2 diabetic, that's just what it is. Let's start to reverse this. And so I do believe that where we're headed with the 1115 waivers that are coming out in Medicaid that gives you the option to offer food as well, I think in the next 3 to 5 years, I think that we're going to get there, that there's going to be that budget within healthcare that a plan has to offer food to those who have chronic related disease caused by food.
3 to 5 years, that's not long at all. I love it. It's so like hopeful. So you mentioned this whole person approach. And so Mike and Taryn, I'm wondering, both of your companies need to look at the whole person. It can't just be sort of these, particular elements. How do you do that effectively? Taryn, do you want to go first?
How do you look at the whole person? Well, I mean, holistically, mind, body, spirit, right? So you have people coming in and you want to consider, what is their mental health, right? And we know that actually food can have a big impact on our mental health. And right now there's no better time than right now to think about that. And we know that higher quality diets are associated with lower depressive symptoms. And so I think just that idea of the educating again around how food can actually work on that kind of whole level, that mental level, and getting people really engaged and excited about what they can kind of proactively do. When they start to experience the benefits, kind of those tangible benefits of feeling better, having more energy, it becomes this kind of virtuous cycle where they want to continue to do that stuff. So we have to encourage them to make those changes, have those experiences, and then they start to share out with more people. And I think actually, Mike and I were talking earlier about, how even pharmacists and other healthcare practitioners can play a really big role in inspiring that kind of change. So I'm really on board, and actually I've been doing a lot of work over my career to help inspire people, the practitioners, the people that are kind of on the front lines. And sometimes that's even, it's not necessarily in the healthcare practitioner's office. You need these other, channels by which people can get that information.
Absolutely. Yeah. So Mike, I pick up my mom's prescriptions for her. She's sort of housebound now. And pharmacies and pharmacists have become very important in my life since the COVID-19 pandemic because they give me a lot of information. They also cheer me up. They look at the whole person because they understand that my husband and I are sort of my mom's caregivers. Are we asking too much of pharmacists to look at the whole person? Because, it's a lot to put on these professionals.
I think the short answer to that is no. Pharmacies and pharmacists play an important role in the communities that they're located, right? You're 10 times more likely to go see a pharmacist than you are your doctor. In many instances, the people that run and operate the pharmacies are your neighbors. They're the people that stand on the sidelines with you. They're people that are intimate in terms of helping you move to point B in your health, assuming point B is some more favorable place. So no, I don't think it is too much to ask. I think those people are appropriately positioned to take on a broader set of responsibilities and taking a step back in terms of how we've traditionally treated our patients. You can see where all of this is moving. The idea that we're going to look at people holistically is exactly the right approach. We're going to move to a system where people are rewarded on the outcomes in terms of compliance and adherence, and living longer and healthier lives. I go back to what I said before. 90% of Americans live within 5 miles of a pharmacy. Half of those people live within 1 mile of a pharmacy. So from my perspective, when you look at the screening, you look at the testing, you look at all those things that are residing in these community high-touch care providers, they're sitting there as an underutilized resource to really pick up the mantle for food as medicine.
Sure.
And the time is now. The time is now. Yeah. You can feel that. How many people are in this room? How many people have coalesced around the idea that we can no longer continue to treat the results of a problem? That makes no sense. We have to go back to the beginning of this and address the fundamental issue. There is no good place to stand after the problem has already happened.
Sure.
And that's what this is about. And as a representative of the 40,000 pharmacies across our country, I'm here to let you know we're prepared. We're ready. We're ready. We think it's an integral time to put our money where our mouth is here and be the care providers that we know we can be.
We've given a lot of, exactly. We've given a lot of applause to dietitians and nutritionists and other medical professionals today, but I want to give a shout out to pharmacists who are really on the front lines of so many things that we're dealing with right now. And so, Mike, I do want to continue with you. I want to know what you envision. What's your vision for the future of partnerships between pharmacies and grocery stores and how they dispense food as medicine?
Yeah, so I look at this is about collaboration and collaborating in good faith with other shareholders that are objective in their desire to move forward and organizing new kinds of chaos in the service of their customers. You know, when you look at the 40,000 pharmacies that are scattered across the country, many of them are grocery stores. I think Senator Warren said it best. These should be subsidized prescriptions, just like a regular prescription, and they should be our first go-to as we're looking at really addressing the foundational issue for what has become diabetes, a diabetes issue, cardiovascular. Just look at the facts, look at the dollars. They're unsustainable by virtue, by every standard. We have to do this. We're morally obligated to do it.
Yeah, absolutely. Ashley, do you have that moral obligation? I know you do.
Oh my gosh, we take so serious here at Farmbox RX this movement. We were the first ones to break into healthcare, and we knew that, I mean, the pressure was on, right? Like, they're just looking for something to, you know, crack a hole in what we're doing. And so the data that we give back, you know, to CMMI, which is the innovation hub for the Center for Medicare and Medicaid, the data we're giving back to the health plans, it goes around what she was talking about of engagement. That's everything to us, because it's the ridiculously obvious notion that if you eat healthy, you're going to be healthier. And it's a very common misconception that just because somebody is low income, they don't want to eat healthy, they don't have accessibility, affordability, and they don't understand what to do with what is put in front of them. That's not from a bodega, that's not unhealthy. So that engagement piece of how we get members to engage with this box in other preventative health measures that the plan can wrap their head around, that they need these members to go do, that is what's led the door open, that we believe is going to be to the ultimate produce prescription.
Yeah, and it's breaking those stereotypes, which is so, so important when we're talking about all of this. Since we're sort of at a key part of the afternoon, I want to make sure that you all get a chance to talk about two things. And if you can say them quickly, you can talk about both. What pisses you off? Because I think that we all have challenges. And then lastly, what inspires you? So Taryn, what pisses you off?
Is, well, I do think that, again, we don't have access to enough of diversity, I would say, of the foods that really can be powerful medicine. We really don't provide those fresh access points, and then people really aren't aware that there's other ways to kind of supplement their diet with nutrients and with phytochemicals. And I think herbal medicine is one way that you can really expose people to more phytochemicals within their diet. So I want people to know that yes, food, but also there's a lot of other plant helpers in the world that can help people on their journey. And what inspires me is that people are actually turning towards food, and they're turning towards plants. And as they are looking for answers in their life outside of just the pharmaceutical approach, that they're realizing that they're coming back to kind of this innate understanding that what you put in your body actually does have this major impact on your quality of life. And the research is also validating that. I mean, you look at the research on botanicals, and it has been exploding over the last couple decades. So I think we are starting to understand more just exactly how powerful food and plants as medicine can be.
Diversity is certainly key. Mike, what pisses you off quickly, like 10 seconds?
Willful blindness drives me crazy. Pretending that a problem doesn't exist makes it infinitely worse. I hate that. What inspires me is when people come together in the service of something bigger than themselves to liberate people to be the people that they're obligated to be. We're doing that through a Food is Medicine initiative, and when we do that, the people that benefit from that inspire the people around them to be better versions of themselves, and then everything isn't kind of better, it's way better.
Love it. Ashley, what pisses you off?
a lot of things, but the red tape, and really that common misconception that just because people are low income or live in a rural area, they're in a food desert, that they don't want to eat healthy.
Right.
That really drives me to my core. And what really inspires me is everybody out here, because I know 3 years ago when I started off in healthcare, they looked at me like I had 4 heads. Like, you want to deliver produce to who? My members? So the fact that the movement has grown so much in just the last few years, that's what inspires me.
The movement has really grown. That's thanks to so many people in this room. That's thanks to the people on stage. Please give them a round of applause. Thank you. So there's a lot to cover on this topic. You can exit if you'd like. There's so much to cover on this topic, so we're going to continue this conversation with part 2 in just a moment. And let me introduce our panelists who will join me on stage in just a moment. It'll be Chef Ismail Samad, the founder of Nubian Market. So excited to talk to him. Gordon Reed, the president of Stop and Shop. Pam Schwartz, the executive director of community health at Kaiser Permanente. And Brooks Tingle, the president and CEO at John Hancock. While they join me and get settled, please enjoy these 2 videos shared by U.S. Congressmember Ayanna Pressley of Massachusetts' 7th District and Lori Trahan of the state's 3rd District.
Hello, everyone. Congresswoman Ayanna Pressley, representing the Massachusetts 7th Congressional District. I wish that I could join you all in person for this critically important convening, but due to a longstanding scheduling conflict, I'm joining you virtually to express my gratitude for your commitment to end food insecurity for good. In my opinion, hunger, food insecurity is a humanitarian crisis, a moral failing, and a policy choice. It is unconscionable that in one of the richest nations in the world, that millions of Americans struggle to put food on the table to nourish their bodies. I want to thank my Massachusetts colleague, my brother in arms and in good trouble, Jim McGovern, our ranking member on rules, who has been a global leader in the fight to end hunger and has been our collective North Star on this and so many other issues of consequence. I also want to thank the Biden-Harris administration for responding to this national crisis with the urgency it warrants, and by leveraging partners in Congress and stakeholders across our country to inform the national strategy on hunger, nutrition, and health. The second convening on this topic in 50 years. I'm proud to say that our office was a partner in hosting a local convening with impacted families, providers, academics, and advocates in East Boston. That hearing took place in East Boston, and the findings of that were transmitted to the White House and informed the national strategy. What we heard in that hearing reflects what we know writ large in the policymaking space. These issues are intersectional and interconnected. Access to healthy, affordable, and culturally responsive food is foundational to the health of the individual, family, and the community. Food is medicine. I want to thank each and every one of you for centering those most impacted as we work to finally end food insecurity. I'm grateful for your continued sweat equity in this fight, and I know that we can get this done.
Good morning. I'm Congresswoman Lori Trahan, and I'm thrilled to be joining you virtually at the Food Tanks Boston Summit in partnership with the Friedman School of Nutrition, Science, and Policy at Tufts University and the White House National Strategy on Hunger, Nutrition, and Health. Today we gather with a shared understanding of the profound impact that food has on our health. Food is not only a source of nourishment, but also a powerful tool in preventing and treating disease. We have the opportunity to transform our healthcare system by integrating nutrition as a cornerstone of medical practice. It's crucial that we embrace food as medicine and ensure that everyone has access to the nourishment they need to thrive. By leveraging the power of nutrition, we can prevent and manage chronic diseases. We can promote healing and improve the quality of life across our country. In Congress, I'm committed to supporting policies that prioritize food as medicine and that break down systemic barriers that block access to healthy and affordable food. An early step towards this is investing in our community-based nutrition programs that spearhead this important work on the ground and in our communities. Let's make the most of this incredible opportunity to advance the food as medicine movement. Let's learn from one another, share our experiences, and develop actionable strategies to make a lasting impact on the health and well-being of our communities. Thank you for everything you do, and thank you for being a part of this transformative movement.
I want to thank the congressional members once again for taking the time to share their viewpoints with us. Before we get started with the panel, I want to encourage all of you to use the hashtag #FoodTank across all social media channels to share your thoughts and your questions and critiques with us. We really want to hear from you. So thank you to our online audience who stays really engaged during a lot of these events. And I'm so excited to continue this conversation about how the private sector can continue integrating nutrition and health and everything that they do, because they have such a power. So I'm pleased to see all of these panelists. And Pam, I like starting with you. Because you and I have talked a lot about this, and you've mentioned that there's a real interest in food as medicine from healthcare professionals. But there are a lot of barriers for helping them do more of it. We talked about education before. A lot of them don't have the education, but they understand the power of food as medicine. How can we overcome these barriers?
Thank you. I just want to start with saying that I've had a permagrin all day. It's so exciting to be here and to hear all the repetition of the panels. And there's so much communication to healthcare. So as healthcare, thank you for all of that. And just to start with saying, there is so much enthusiasm in healthcare right now for food as medicine. So from our members and our patients, maybe backing up a second, I'm from Kaiser Permanente, which is an integrated health system. We're at 12.7 million members across 8 states and Washington, D.C. And what integrated means is we're both health insurance and providers. And so I want to say that so that you can hear what I'm saying in the context of both health insurance and providers. So much enthusiasm from our members and our patients, and also from our clinical colleagues. It is not abnormal for me to get a email or phone call on a regular basis from physicians who are on the front line, or physicians or the care teams on the front line saying, we need this, and we need this now, because they're seeing what we've been talking about today on a regular basis, the diet-related disease in their patient population, and they are saying, let's get into traffic here. To your question about what are the barriers, I think it's very clear that there is more and more, food as medicine is rapidly increasing inside healthcare. That is happening. It's also clear that if we want this to get into the fabric of healthcare, we have to continue to build the evidence about what works and under what conditions, and the business case inside healthcare, so that we can scale this and so that we can sustain this. So to me, those are the biggest barriers. And then we have other barriers like workflow and burnout and all the things that have been said also throughout the day. But the biggest ones are, what should we be doing, to whom, which patient populations, which disease categories, for how long. And once we can do that and be able to communicate that and get that into our plans and our budgets, it's a whole new day.
I want to come back to this idea of building a business case in a minute, but you mentioned enthusiasm from not just healthcare professionals, but from patients, and I'd love to hear a little bit more about that.
So we've been doing food as medicine in a lot of pilots, and the patients in those pilots are super excited about what was talked about on the last panel. So like a farm box being delivered to their doorsteps with healthy food for them to make dinner, recipes that tell them how to cook it. For patients we just finished actually a study, a randomized controlled trial, because that's also what matters inside healthcare, is making sure that we're doing the most rigorous science. And so these patients participated in this. They were diabetic patients with Medicaid, mostly with Medicaid, and we sent boxes of healthy food, mostly produce with a couple of other healthy items, to their homes once a week for 6 months. And the enthusiasm of those patients was just amazing. We've been doing studies, also randomized controlled trials with medically tailored meals, also enthusiasm from those patients. So we're starting to get into traffic with the pyramid, basically. We have all levels of that pyramid going in pilots or sometimes in full force for SNAP. We have SNAP enrollment going on. We've helped almost 125,000 members enroll submit their applications for SNAP. And what we learned from that is that healthcare has a role to play in that. Our patients want us to help them there. And then when we help with SNAP, we can also help with other government programs, like helping people with their internet, also WIC. And so we're starting to take a look at how can we be a good partner to our patients in getting them enrolled in government programs and getting them to be able to participate in food as medicine programs.
And that's really the key. How do you become a partner with folks? And so, Gordon, if I can turn to you and sort of keep going on this idea of produce prescriptions. For those who might not be as familiar, can you talk about how Stop and Shop is using produce prescriptions?
Sure. We were the first in Massachusetts to adopt or to work with Fresh Connect. And that's been really successful, and we continue to grow with that. We've actually, in Montessori Hospital down in the Bronx, we've actually sponsored a trial where we're actually providing the finance for the experiment or the trials to take place. And so we're absolutely committed to that. We think that obviously retail in grocery stores are a key part in the food world. And we've taken journeys over the years to get to reformulate private brands, reformulate product. And as you sort of progress, this food as medicine becomes really exciting, because I think there's been a progression. I've been in the States 10 years, and we've gone from food banks just taking any sort of foods and sugary drinks, etc., to actually setting standards that they want to have food, or the quality of food and healthy food. And now we're getting to this stage where we really are sort of, how do we reach out and serve people and deliver? And Fresh Connect and the food produce prescriptions really is fundamental to it, and a great example of food as medicine.
Yeah, and it's about those partnerships. You have to keep partnering and finding different ways to partner. Chef, if I can turn to you, Boston Medical Center shares recipes on their website contributed by Nubian markets. And I love this because you're providing a lot of diversity, not just in terms of, the diversity of foods, but the sort of diversity of thought around food. And I'm wondering if you can talk about that.
Yeah, so we didn't just partner with BMC on the recipe side. Mike, all right. Is that better now?
That's great.
All right, cool. But no, I got to say, they didn't just partner on the recipe side. It really was building this thing from the ground up with the community to actually create the food as medicine that we want in our communities. And recipes is one small chunk of that. And so what we did is we worked with BMC to ensure that investment went into creating business cases that could be scaled up from the ground up from a grassroots reality in Nubian Square. And the recipes show up so everyone in Boston can actually celebrate the collective diaspora from our perspective of what we say is medicinal to us, given the recipes that we design in collaboration with Boston Medical Center. So they're allowing us to take the lead, sharing our intellect and our creativity. So we're not just looked at as a group of patients, but we're also looked at as a very diverse group of people with different talents to actually center the narrative differently around food as medicine.
It's so great. And that narrative has really needed to change for a long time, because not everyone has considered food as medicine, but chefs have been at the forefront of this. And I'm wondering if you can talk about that a little bit more.
Yeah, chef has been on the forefront of creating the tastiest burger that is not medicinal, unless you look at it as I just want to go get a burger and celebrate with my family, which of course is medicinal as well too. But yes, we also are at the forefront of trying to make sure that we're working directly with farmers. And at Nubian Markets, we center Black farmers as that reality, so we can talk about sovereignty both on the land side and the consumer side, so people can choose what they would like to see, and then we can collect the data at the grocery level to say this is working, this is not. Right. So that's kind of the interplay that we kind of sit at.
And again, it's building the business case, which is so important to all of this. Gordon, if I can turn to you and talk about. Sorry, I want to go to Brooks next. What role do you think that insurance companies have in incentivizing healthy eating?
Sure. First of all, great to be here and represent John Hancock. 161-year-old company operating a few blocks away here in town. To me, it's really odd that our industry and our business has not been at the table on these important matters. If you know anything at all about how life insurance works, you buy a policy, we collect your premium, we invest those premiums, hope you live a long time, and then when you die, we pay the death benefit to a loved one, presumably. So the longer you live, the more money we make. I'll be completely blunt about that. But despite that really simple, basic fact, for literally hundreds of years, our industry issued life insurance policies on people and sat back and said, I sure hope they live a long, healthy life, and did absolutely nothing to try to achieve that outcome. So in 2015, we introduced a first-of-its-kind program that incentivizes and rewards our customers for taking steps towards a longer, healthy life. I won't get into it all here in the interest of time. You can do a search on John Hancock Vitality if you're really bored later. But it's basically an app with incentives and rewards. Anything you do that correlates with longevity, physical activity, good nutritional choices, preventative screenings, you get points. Those points accumulate, and you get a status, sort of like you would on an airline or something, bronze, silver, gold, platinum. The higher the status, the larger the premium discount is that you enjoy on your life insurance premium, and the greater the value of a whole bunch of other rewards. So we launched this program in 2015, started it with a really heavy emphasis on physical activity. Unfortunately, we learned quickly, as I learned, you can't exercise your way to good health at some point in life. Nutrition really, really matters. So we went out and looked for a partner. We found the great folks at the Friedman School and added a heavy nutrition thread to our program. And I'll just give you a couple examples of how we've tried to commercialize this in what we think is a perfect sort of shared value situation. Sometimes customers don't do things that are good for them and good for us because what we'd consider the right choice is a more difficult choice. In the case of nutrition, for reasons I'm sure everyone in the room understands well, sometimes healthy foods are actually more expensive than unhealthy foods. So we partnered with over 17,000 grocery stores in the US, I'm proud to say, including Stop and Shop, where our customers can get 25% off the cost of fresh produce at grocery stores. They write at the cash register, they buy a bag of apples, present your Hancock card, and right on the receipt it'll say $5 bag of apples minus $1.25, John Hancock Vitality. So trying to make the right choice the easy choice. We have a game that our customers can play called the Vitality Squares, where they turn over little tiles. It either turns over something unhealthy, like a donut or a hot dog or what have you, or something healthy, like a fruit or a vegetable. The more healthy tiles you turn over, the more points you get, the more rewards you get. So I think the life insurance industry should be a prominent player at this table.
Sure.
We stand to benefit if people live longer, healthier lives, and nutrition is obviously a really prominent part of that.
Yeah, and that gamification of making the right choice, the easy choice, is really important. So Gordon and Chef Ismail, I want to talk a little bit about how stores and restaurants and culinary professionals can better partner with nutrition professionals to help you all access the resources that you need. So Gordon, do you want to go first?
Yeah, well, we have a team of dietitians. Most of them are sitting just over there. And they do a fantastic job for us. They're involved in actually our category planning, our category management. You know, are these products healthy to bring into the business? They're giving webinars and out there in the community working. Christine is in their Roxborough store and does a fantastic job there, an in-house nutritionist. So we have, you know, a lot of resources ourselves. But you know, I keep saying to everybody, look, we are desperate to partner with people. This is really important to us. As a food retailer, I think we have a requirement that we're involved in food as medicine. And the way I look at things is we have assets that we can use. So we have 60,000 people. We've got 400 stores. We have relationships with the biggest manufacturers in the country. And so what do you want to bring? I could offer that to you. What do you want to bring to work with us? What are your ideas? How can we sort of share our resources? And that way, I think, will make a difference, because there's a lot of really good people, a lot of good work getting done out there, but it's getting done in isolation. And I think if we can start joining the dots with all of these things, you know, the health insurance is a great example. You know, if you eat healthy, you're going to be healthier, you know, you're going to get a cheaper sort of insurance premium. And that's the sort of thing that we're open for.
Yeah, we've been hearing that all day, the silo breaking, the connecting the dots. Chef Ismail.
Yeah, speaking to some of the silo breaking, I can talk about two things.
Please.
In addition to Nubian Markets, I'm also leading work in Harlem with the Corbin Hill Food Project, and we actually have a NEFA grant of about $1 million to do food as medicine work in partnership with Harlem
So cool.
and the Bronx. So
Yeah.
the original project was designed to actually make sure we're creating community council within the community, and not just an advisory board, but actual community council. As soon as you add council, that's decision making that's happening at the community levels, and you're working with other organizations to design right from the beginning what the community would like to see.
Yeah.
And so that's one of the innovations that we're doing, and also making sure that the data stays within community, within our own version of a repository, so we know that the data stays within the community as well. And so that translates into something that we're beginning to do at Nubian Markets in partnership with Boston Medical Center as well, which is with Rewire Health. Well, I don't know if Olivia's in here, but anyway, but with a nutritionist and dietitian over at Boston Medical Center has designed an app to be able to have Nubian Markets hold the data that we are getting from the customers around like what's moving, what would they like to see, what changes needs to be made on our offerings, what are they cooking at home, what ingredients do we need to stock, and all that stays within our community and not within a construct of a space that's not owned by us. So that's how we're trying to break down the boundaries of, break down those barriers and those silos that you're talking about. It's really delivering the types of models that are completely owned by a community right from the beginning, and then working with partnership with anchors around us, so that we can create, Black and Brown owned anchors instead of anchors that are not owned by us in our community.
Sure. Round of applause for this, because it's such a great project. It's such a great concept. And it can be replicated in other communities, and that's what you're seeking to do.
Yeah, we put an S on the end of Nubian Market, so hopefully we can become many markets around the country, because if we don't have Black-owned businesses that are actually centering our Black products. Right now in Nubian Markets, we have over 35 different Black-owned products that are produced and or grown by Black makers and growers in Massachusetts and around the country. And so then we can put like Sweet Baby Ray's, which comes from like Big Food, put on the bottom shelf, and put Hillside Harvest or Happy African Gourmet in the center of the shelf, prioritizing what we want to prioritize, which of course is our medicinal products that resonate with us in our community.
Right.
So.
Absolutely, so critical. Thank you so much. Yes, please. So Pam, I want to go back to this business case that needs to be built when we're talking about, getting the private sector on board for this concept of food as medicine. And the business case is there, but there isn't always the sort of momentum we need. Kaiser's good at it, right? But how can we encourage others to be good at it?
I actually don't know that I agree that the business case is there, so I'd be interested to
Yeah,
hear why you think that.
Yeah, of course.
Because I think it all, well, when I say the business case, I mean we have to figure out which, this is what I said earlier, which disease categories, which target populations, and which duration, so that when, for example, when you're deploying an 1115 waiver, you have some choices. You have some choices in which disease categories, which populations, and we have, just as an example, we have 1.3 million Medicaid members. So if you multiply 6 months of produce prescriptions times 1.3 million, that's a lot of dollars. So how do you build the business case for the most effective interventions that get to at the end of the day, everybody, I think, wants the same thing, and that's healthier lives, better well-being, lower chronic disease, and all the stats that we saw earlier. And we also know that our members are struggling. We've surveyed them even as recently as just a few months ago, and we asked our members about their social needs, and what we saw was almost a little over 2/3 of our members said they had at least one social need. So food, housing, transportation, those kinds of things. 2/3 of our members had at least one, and 20% had 3 or more. And if you look inside the Medicaid population, it was 90% had at least one social need. If you look at food and nutrition insecurity, we saw 25%, so higher than the national, depending on which data you look at, of what Dari showed on his slides. That's a lot of people that are struggling, and so how do you target that? And so that's what I mean when I say business cases. I mean like what should be deployed, and how do you pay for it, and somewhere it has to, you pay for it instead of what? So, because we're a prepaid health plan, and that means you get money at the beginning, just like you, and we are incentivized to keep people healthy, so who should we focus on keeping, who to focus on is really what I mean.
I think it's really easy to overthink these things and really get caught up in a business case. I can tell you, if I want to acquire another company or enter a new market, I've got to go to the board with a business case. But when it came to doing this vitality thing that I mentioned,
Sure.
I just got in front of the board and said, this is the right thing to do. Why would we not help people? And I think what you hear from everybody here is, yes, I mean, most of us are for-profit enterprises and so forth, but a strong sense of values and conviction is what it takes to get these things done. And I can tell you, I didn't a business case for this vitality thing. We spent tens of millions of dollars on it, and the return turns out, thankfully for me, been phenomenal. But or I wouldn't be here today. But it is easy to overthink it. Shouldn't a life insurance company want people to live long, healthy lives? Shouldn't a health insurer want people to be healthy? I mean, all the values represented here. So I think this type of work starts with values and conviction, and the business follows.
I love that we're looking at the sort of moral part of this instead of just the dollars and cents part of it. And so from Stop and Shop's perspective, I mean, you're a company that needs to make money too, but you also see the moral side of this.
100%. We've supported food banks for decades. We've been involved in the food industry over 100 years. So, it's just the right thing to do. You get to the point where we have a responsibility to stop food waste. How can you stop food waste? You give it to people who are hungry. And last year we donated over $40 million in food to good causes. So, it just makes sense.
Thank you all so much. The private sector certainly has a responsibility, and thank you all for living up to it. I really appreciate talking to all of you. Please give them a round of applause.
Thank you.
Thank you. Right now, I just want to take a quick moment to thank some of our in-kind partners whose delicious drinks and snacks are available for you to try. Thank you to Oatly, to Tony's Chocolonely, Quinn La Colombe, and Rootless. We're now going to show 2 short videos from U.S. Congressmember Jack Auchincloss of Massachusetts' 4th Congressional District and U.S. Senator Ed Markey of Massachusetts. While the videos play, I will introduce our next panel, which will look at how the nonprofit sector is working to advance food as medicine interventions and why these programs are so important. For this conversation, we have Concetta Paul, a member of the Community Advisory Board for the Food as Medicine Massachusetts Coalition, Dr. Tia James, the Vice President of Mission at Boston Medical Center, Zoe Simmons, who is also a member of the Community Advisory Board for the Food as Medicine Massachusetts Coalition, David B. Walters, the CEO of Community Servings, and our moderator for the next 2 sessions, Deborah Becker, the senior correspondent for WBUR, National Public Radio.
Hi, everyone. Congressman Jake Auchincloss here. Thank you all for your critical advocacy around food insecurity. I'm excited to see you all shape public policy by emphasizing that food is medicine. By focusing on the integration of nutrition and health and supporting important research in that vein, you are advancing the Biden administration's national strategy on hunger, nutrition, and health. I look forward to hearing about the rest of this summit and will continue to advocate in Congress to end food insecurity.
This is Senator Ed Markey, and I just want to thank Tufts University and the Food Tank for hosting this incredibly important event. Access to food is vital, yet 12.5% of households don't have access to enough food for an active, healthy life. They struggle to pay the grocery bill, or they live in communities without a grocery store nearby. And when people don't have the food they need, their health and economic security suffers. That's why I am pushing to protect access to nutritious food by fighting to expand, not cut, SNAP benefits. No one should have to wonder how they will get their next meal. The fight for food security is not easy, but it is essential. So thanks to each of you for your work strengthening our nation's health through nutrition. You are doing truly God's work here on earth. Thank you.
Very nice.
Welcome, everyone. Hi, my name's Deborah Becker. I work for WBUR here in Boston, and I'm really excited about this panel. We'll be talking about what the nonprofit world is doing in this space, and we have some great panelists in both sessions. And we also have some folks here who are recipients of medically tailored meals who will talk about their experience as well. So we think we're bringing you a great picture, but we have very short amount of time. I have a big clock in front of me warning me not to talk too much. So we'll get right to the discussion. So first, I'd like to introduce you to David Waters, who is CEO of Community Servings. And I'm going to start by, because I'm not sure everyone's familiar with what nonprofits are doing in Boston, just a brief overview of your work and how you're addressing this issue.
Thank you, Deborah. And thanks to Tufts and Food Tank. We're so excited to be here, and we are a proud research partner with Tufts as well. So I'm David Waters. I'm the CEO of Community Servings. If you don't know what we do, we are primarily a medically tailored meal provider, but we also do a lot of research and policy work at the state and national level. We do a food service job training program, a large local foods program, but really focused on the topics today around food as medicine. This year, we will provide 1.2 million medically tailored meals, all of which are scratch-made and tailored in multiple ways to fit the needs of our patients. And one of the stats I really love is that we will deliver to people in over 300 towns and cities in Massachusetts and Rhode Island this year. So really, probably the widest reach of any food insecurity program in the region. But in addition to that, we have done some really significant research around the ROI on medically tailored meals. So if you're not deep into this, like some of us are, we published in the Journal of the American Medical Association research on people that we had fed, and we discovered that we saved 16% on their healthcare costs net of the cost of meals, a 49% drop in hospitalization, 72% drop in referrals to skilled nursing. So that is really the building block, the foundation on which a lot of the work of food as medicine is done, in that we can prove that it works. We can demonstrate to healthcare that this is a smart investment, and to the government, although the CBO doesn't always agree with us. And more recently, we have 3 large NIH R01 studies going. 2 are randomized control studies, and the third is a partnership with the Friedman School and UMass Medical School, looking across 9 different hospital systems at the provision of medically tailored meals. It will be the largest study of medically tailored meals in the country to date. With that data, we now have 22 healthcare contracts. So we are, through the 1115 waiver and other vehicles, we are one of the largest in the country probably for the number of healthcare contracts that we have. And then I just want to do a quick plug. The 2 newest programs that we launched this spring, one is a program for pediatric patients, developing diets specifically for pediatric illnesses, and similarly for high-risk pregnancies and pregnant people. I just get so excited about thinking of how we can use food in so many different healthcare settings.
Thank you. Thank you. Thea James, she's with Mission at Boston Medical Center. And would you tell us all a little bit about some of your work? We heard some from Nubian Markets, some of your collaboration with Nubian Markets in the for-profit panel that preceded us. But I'm wondering if you could tell us a little bit about what you do.
Sure. So I'm at Boston Medical Center Health System, which, as many of you know, it is, it fits under the category of one of America's essential hospitals, which used to be called safety net hospitals. And what that that means in one's mind, that poverty. When you think about the patients who come there, and I think one of the things we know that is a root cause of poverty is not having access to economic inclusion. And so we are not unlike, most well-meaning people. When people don't have things, we always want to fill the gaps and provide them with what they don't have. But I think one of the things that we have done and really try to hold ourselves accountable for is to do a bit of interrogation to really understand why people don't have things. You know, what most people do, and I think, again, this is what well-meaning people do, they would look for more opportunities to provide more people to have access to food when they're food insecure. But we have interrogated this situation to understand why they don't have it. We want to go to the root cause. And again, the root cause is economic exclusion. And so a lot of the things that we do are a part of an ecosystem. You know, we work upstream and we work downstream. In terms of upstream, we have created pathways for people in 7 zip codes in our city of Boston to living wage paying jobs inside Boston Medical Center. And once they get in, they don't just stay where they are. You know, we have programs in our Human Resources Department that enables them to go through professional development, go from entry-level jobs up to managerial jobs, and we are creating pathways also for director jobs, for example. We also have recently started an opportunity for patients to do the same. We screen patients for things they don't have, things they're interested in, opportunities they want, with education and employment being one of them. And, you know, we now have opened up that opportunity for our patients, you know, to go through education and have access to jobs. The other thing you actually heard about already from Ismail Samad. I wish I had been able to hear him, but I was en route to hear. But investing as part of the ecosystem in small businesses. And it was very, very interesting. You know, when we invested in that market, I will say that it was a different market when we first invested in it. It was built out by some, previous owners, but the store didn't open because of the pandemic. And they said they'd identify us 2 local operators, and one was Ismail. But they had no interest in being operators with the experience they have and the knowledge they have, because they wanted to own the business and the physical space, which makes complete sense, because then they would, contribute to building generational wealth for themselves, their employees, and they know, and including the entire supply chain. Everything they do is focusing on root cause and upstream and enabling people to be able to thrive and, have generational wealth. The other things we have, we had the first hospital-based prescription food pantry, and doctors can write prescriptions for patients, but these patients are also screened, for education, employment, and that type of thing. Actually, Tufts did a study on that pantry at one point. One of the questions they asked the patients is, what would it take for you to not need this pantry? And they said they couldn't imagine it. And what I will say about that is, it says a lot about us. You're not being intentional and thinking about what the root cause is, and coming up with pathways for people to have opportunities to not need that. Because it's not the decision path we make for ourselves or our families or our friends' kids and things when they don't have things. We put them on paths to have self-determination, but for others, we send them to subsidies that are not designed for people to someday not need them. So those are some of the things we have. And the last thing is we have a rooftop garden. Kids come there and, they learn to farm, and we also use that food for our patients and our employees in the cafeteria.
A lot going on there, a lot. Thank you. And we'll get back to some of the policies, I think, in what both of you are doing, but I do want to make sure that we leave time to hear from Zoe and Conchetta. Zoe Simmons, you're a member of the Food is Medicine Massachusetts Coalition, and I wonder if you want to talk with folks about your experience with medically tailored meals.
Well, I think what I'd like to say is it's hard. You asked me what would I do? I wouldn't be a survivor of Me Too from my family. I wouldn't be embarrassed.
It's okay.
And I wouldn't be publicly here, no, I would, publicly here telling everybody, because I'm on video and I'm going to be on YouTube. And I can tell you why that's unusual, because I've also been a caregiver of my parents. I had to, because my family was so awful, I had to disown them. They're missing out. And do the right thing, take care of my parents. I have health issues that started that a little bit. I'm allergic to shrimp, scallops, crabs, things like that, and gluten and certain medications. And I had a bunch of seizures. My first seizure, for those local, I landed at the feet of Speaker Tom Finneran. Second one, I fell at the Worcester Centrum down the stairs. I had had a lot of shrimp the night before, and I had a few muffins for breakfast. And poor Governor Deval Patrick was about to take his acceptance speech as the gubernatorial candidate, C-SPAN, CNN, historical, and I fell down the stairs, had a seizure. He had to pause. I did collect myself years later. My first name is Antigone. My middle name is Zoe. My last name is Simmons. And you can call me Tig, because this is what's happened here. I was Antigone, and I told my truth on Facebook because I was so scared. I was so alone during COVID with just my dad. I figured if I caught COVID, I'd die and nobody would know. But you folks, the work that you all do, I'm happy to say the open pantry in Gloucester has pretty much saved my family and my life. I took care of my mom. She had cancer. She was my favorite person, my soulmate, everybody. I hope you have someone like that in your life. And she died right before COVID, and my family was even more horrible. So anyway, the point is that then COVID came. My dad had had strokes, dementia, other issues. He was an alcoholic, and he was not a good person, but he promised to do penance after my mom died, and he did. But he just died a couple months ago. And so what I'd like to tell folks is the last pretty much tidbits is I'm a lawyer. So if you want to talk about education and training, this can happen to anyone. And it's hard to say because my career name is Antigone. But when I was trying to hide from my awful family and people, I'm shaking. I see my hand shaking.
It's okay. It's okay.
I had to tell, I changed my Facebook page to Zoe, which is my middle name. My mom did well. First name, tragedy, middle name means new life. And so people didn't know. And last week when I called, I didn't know what this panel was. I had no idea. And I'm going to segue back to, I was getting food from the food pantry, and somebody had something, oh my God, gluten-free food. It's so expensive, it's so expensive. And then I forget the lady's name. She said, oh, there's a program at the pantry here, and I have a flyer. It's all about the flyer, ladies and gentlemen. A very simple, straightforward flyer. But the problem when I was living with my parents, taking care of my parents, and what you people all talk about is programs for children, programs for school. I can tell you that my alcoholic father, we were on welfare. I didn't know that the morning breakfasts weren't everybody's, just so you know, at school. Where was I?
No, you were talking about the pantry.
Oh, okay. Sorry, I'm not good at this.
That's okay. You're doing fine.
And so I contacted them. And what's wrong with a lot of this is to get SNAP, to get other programs, and no disrespect to anyone, but you've really got to be poor. I got a part-time job to try and get out of the house, to like do something and use my brain. And I work at the tractor supply store, and people bring in their dogs or cats, and I have a kick of a time. And now it was difficult to figure out how I was going to get the program because of the money. And like SNAP, it's had a household, it's a whole combination. But now it's just me. And as me, I'm going to maybe apply for SNAP, but it's awful to think that people are so embarrassed, shamed, and all such things. And professionally, I've now today realized how brave I am, because my whole career could be ruined. But if anybody knows a job, I need one. And as you can tell with my political background, I know every single one of the people who represent our delegation. I was the chair of the Democratic Party in the city of Haverhill, 60,000 people when I was in law school. I've been off the grid. And now to try and explain why is happening right here and now. So I'm taking a lot of time, but the flyer is important, making sure that all you academics and professionals with such big hearts know how to communicate to the people who are receiving. You'll notice my voice just changed. The advocate in me says, we can do better. From the standpoint of, this is like undercover boss, right? I've been there, now how do I tell you? And I'm now going to pass this off to my next person because I don't know how long I should be.
She has a mic. Conchetta Paul, you're next, and you are also, thank you. Very good, very good. Conchetta Paul is also a member of the Community Advisory Board for Food is Medicine, Massachusetts, and she can talk a little bit about her experience as well.
So thank you. Yes, my name is Conchetta Paul, and thanks to the organizers for inviting me to this panel. So I also, like Zoe, received home-delivered meals in 2021. That was after a car hit me on a crosswalk right outside of Tufts, and I ended up in this hospital. My dislocated right ankle bone, it burst through my skin. I spent months in a knee-to-ankle splint. I had to use a walker and stay off my feet, so I couldn't cook. And because I live alone, I had no other option for meals. So I had never needed those services before. I knew they were available, but I did not know how to access them. So I went online and I searched frantically, and I eventually stumbled on community servings. Now, back then, there was no website, but now we do have a Food is Medicine Massachusetts website. So as a beneficiary of home-delivered meals, I can attest to their usefulness and their dependability. I was especially grateful for the ethnic component, and it was referenced earlier from the Nubian representative, because those ethnic dishes reflected my own food preferences and cooking style. So I found an old ancient Chinese quote which says, "Our actions become our habits. Our habits become character, character becomes destiny." So if we want to change our eating and nutritional habits, we must begin by changing what we think about nutrition and the crucial role it can and should play in our lives and the overall life and health of the nation.
Very good, very good. So I wonder, a lot of the work that we've heard about, a lot of what we've heard from Conchetta and Zoe, I wonder, what do we do to make sure that it is more widely known to people, that there isn't stigma around getting these kinds of services, and that nonprofits in particular can join together so they're not siloed and they can offer services to the greatest amount of people. Would you say that's one of the biggest challenges, or how would you describe it?
Well, first of all, listening to Tig and Conchetta, life is hard and it's complicated, and our health is complicated. And it's rare that, at least for community servings clients, that they have just one illness or just one social determinant or just one barrier. It's many things. And we have to meet them where they're at if we're going to really help them. I think that, like the great speaker from Farmbox RX in earlier panel, I think this is going to happen in the next, she said 3 to 5 years. I was going to say 5. I think from a policy perspective, it's what do we do when it happens? Because there aren't the services in Massachusetts is way out in front of many states. And kudos to us and our progressive public health and administrative leaders. But what are we going to do? So I think it starts with food justice organizations, unfortunately, have to look more like healthcare in order to work with healthcare. So we spent a lot of time and a lot of money invested in HIPAA and data security. We think a lot about scaling. We co-lead the National Food is Medicine MTM Accelerator to scale and incubate new programs around the country. And we're on the cusp of developing an accreditation program that will accredit medically tailored meal programs all around the country. So somebody like Pam at Kaiser Permanente knows that if Kaiser's buying medically tailored meals in California and Colorado, or Pennsylvania, they know that they're going to get the same intervention. And so starting to think like healthcare. And as a former restaurateur and food justice person, that's anathema to me, but that's how we got to go. And so really thinking about the operations of how do we, once we achieve the policy, how do we make it actually happen? And I think that's going to be all of our legacy.
Thea James, what would you say about that? And what do nonprofits need to be successful?
I think in our sector, in the healthcare system, I think, we have to transform the way we think and the way that we act. Most often we tend to go in rooms and talk about what we're going to do, create solutions for what people need. I think we need to start with people and allow them to inform us about, what they need and actually allow them to partner with us and participate in what the solutions are. And in terms of, I would say, government, I'm incredibly proud of Massachusetts and, as David said, how far out front we are and how we lead in many different ways. But I also think that we too, government as well, could help with asking communities, asking the people themselves, and enabling them to invest some of the resources in a different way, in a way that people define best suits them, whether they are people who are in need of something or people who are just in need of economics, some sort of economic stability. So I think it's a collaborative effort. And again, for a health sector, we need to step outside of our own walls and, let people collaborate with us.
Mm-hmm. Concetta, I know that you wanted to.
Can I piggyback on what she said?
Mm-hmm.
Because I think most of us may have heard last week there was a report that said that a full-time worker in Boston must earn $51 an hour just to be able to rent a 2-bedroom apartment in Boston. But understand that the minimum wage in Massachusetts among the highest is still $15 an hour. So the apartment rents, a median rent for a 2-bedroom apartment according to Zillow is $3,200. And so this minimum wage worker is grossing $28,000, and the apartment is costing $24,000. So at the end of the year, you only have $4,000. So no wonder the report says that people have to sacrifice things like food because you're paying for your apartment you cannot afford. So you don't want to be homeless. So you hold on to the apartment, but you sacrifice food. So one of the things I'd like to see is that maybe one of the interventions can be nutritionally, I worded it? Nutritionally tailored meals. We have medically tailored meals for people who have medical, people who are sick. But we can have nutritionally tailored meals for people who cannot afford to eat nutritionally, people who are working full-time. The infrastructure is already there, and I think, maybe with the Biden administration, Tufts, Friedman, they can form a partnership. Maybe you could have a pilot and test it, because you had, during COVID, you had free meals as well, and it worked. So see whether you can test a similar pilot where you produce nutritionally tailored meals for the working poor, the people who are working minimum wage, and because they live in high wage areas and rent, have nothing left to live on.
Well, quickly. Zoe wants to add something, just a couple seconds.
I'm not good at short yet. I'm Greek, it's never gonna happen.
It's okay.
2 things. The goal would be, as I read on the Food Tank website, the largest population of 50 to 64-year-olds are the most in need of services such as this, and that if that's me, if you can't tell. And it would seem to be growing, and that would also be the same people that are caregivers. And the caregiver segment is missed. And then I'm on a happy note. Something that also I am concerned about is, how do I transition? I'm looking for a full-time job. What do I do now? I haven't been to a supermarket in a long time. I don't know how to meal plan. I don't know how to budget. I learned a bit in the Food is Medicine program. I love Robin Stone. But I don't know what to do. And I know on Mass Health, before COVID, I couldn't do, nutritionist was a new thing, and then I couldn't do it on Zoom. And now I'm not going to have a nutritionist. I mean, I don't know. I'm going to need help. And that's a program that I think is one of the best, because it can happen too.
Education will
I
help
hope it does. I'm working on it. No, it's going to happen. Anybody, I could use some help, like on all levels.
Okay.
Thank you.
All right. Thank you. Thank you all so much. Thank you really for being brave and sharing your stories. Thank you for your insights. Thank you.
To all of our panelists. What a powerful conversation. And I want to thank all of them for being vulnerable and for sharing their viewpoints in such a powerful way. I also want to thank Deborah. We're going to ask that they stay on stage while we transition to our next conversation. So in a minute, we will have part 2 of our session on the role of the nonprofit sector. First, we have a very special video from Congressmember Jim McGovern. I have to say, I love Jim McGovern. I love him. He's a superhero. So let's enjoy that video once it plays. And then we'll welcome to the stage our next panel of speakers, including Lauren Smith, the Chief Health Equity and Strategy Officer for the CDC Foundation, Orrin Hesterman, the founder of the Fair Food Network, and Rick Whitted, the CEO of U.S. Hunger. Thank you all.
Hi everyone. I want to add my voice to the chorus of people saying thank you to Food Tank, the Friedman School, and especially to all of today's participants for coming together to talk about implementing the Biden-Harris administration's national strategy on hunger, nutrition, and health. At long last, we are making real progress on these issues. With the national strategy as our guide, we finally have a comprehensive, whole-of-society plan to address the twin challenges posed by hunger and poor nutrition. I often say that there are a lot of challenges we don't know how to solve, but hunger is not one of them. We have the food, we have the money, we have the people, and now we have a plan. And thanks to so many people in this room, we are moving forward with implementing that plan. I'm proud to report that I've been fighting in Congress to pass legislation that gets the ball rolling, and we've achieved some results. Things like a permanent summer EBT program to help address child hunger, Department of Defense programs to assess and address food insecurity among military families, and passage of my bill to reduce food waste by making it easier to donate perfectly good but unused food. And the administration is doing their part too, from expanding access to free school meals and improving their nutritional quality, to expanding access to medically tailored meals, to a new public-private partnership between the VA and Rockefeller Foundation to scale up proven food-based interventions like produce prescriptions. There are so many good things going on, and I have never seen America's anti-hunger movement so strong, so united, and so fired up. And thanks to the work of people with lived experiences, we are finally seeing the real bottom-up change that we need to address the challenges we face. So today is an important opportunity to come together, to strategize, to plan, to compare notes, and to talk about next steps. And I hope that at the end of the day today, we are one step closer to reaching our goal. But tomorrow, the work must go on. Now is not the time to give in or let up. We all need to keep pushing so that our progress is not fleeting, but permanent. Our success will be measured not just by our passion and our perseverance, but by our ability to deliver a healthier, hunger-free America within the decade. Together, I know we can do it, and I'm proud to have you on this team, and I'm proud of the progress that we are making. Thank you for all of your work, and keep fighting.
Nice. Hello, everyone. Welcome to part 2 of Innovative Examples of Integrating Nutrition and Health in the nonprofit sector. We have 3 great panelists here to talk about some of their work and some of the challenges facing the nonprofit sector. So I think I want to start with Rick Whited, who's CEO of U.S. Hunger. We just heard this very inspirational talk from Congressman McGovern about how this is a very exciting time and things are really going well. I wonder, what do you see from your perspective, and tell us a little bit about what you're doing to address some of these problems.
Sure. It's interesting times, and I think it's transformative times. There's a lot more excitement to come, hopefully, when you look at the collective work that we're doing. U.S. Hunger is more than a decade-old community-based organization that initially collaborated with tons of organizations and corporations across the country for coordinated meal packs. Well, that went away with the pandemic. About 30 days into being the CEO, 90% of our revenue was gone, and we had to figure out what is relevance. And I think that the biggest shock to us was realizing after years of trying to get food to places of famine that we didn't ask the most important question, which is, why are they hungry in the first place? So we started asking, and our full cart program, which ships fresh produce and shelf-stable meals across the country, was that vehicle. And we were grateful to have partners that said, we need to feed people in the pandemic, we need to feed families and children, so let's use that program, which had just been in its pilot stage. Well, we just, at the end of every registration form, we asked one simple question. How would this box of food help you? What we didn't realize, and if you fast forward 3 years later, now with almost 170,000 of those screenings, we have a mapped lived experience. They all come with not just health-related social needs questions, but they also come with that question answered, which is a testimonial. So we have this interesting combination of qualitative and quantitative data, very large volumes we've been tracking with the CMS. And so as of this year, that data includes the entire HRSN survey that CMS has used. So the short answer is it's getting rougher for the families that are reaching out to us. The stories are indicating that basic needs are just very difficult to meet, and it's tough for a food organization because we realize we'd been splashing in the downstream puddle of food, never going upstream to try to connect the two together. And so it's interesting when you see those stories telling you what's going on.
What are some of the one or two of the key data points?
97%, very difficult to meet basic needs, literally, 97%. 92% are skipping meals. 60% housing inadequacies. 60% are dealing with other issues, almost 60% chronic illnesses. They're self-reporting. The top 5 are arthritis, hypertension, diabetes, obesity, which in early 21 was in the top 5. In 20, it was in the bottom 20, and now it's number 3. So we're seeing that move. So probably most shocking is that they're eating. They're just not eating healthy because they can't afford it. That's what the stories are telling us.
Well, I think we'll go to Lauren Smith to ask you about this. Lauren's a pediatrician, and she's also Chief Health Equity and Strategy Officer at the CDC Foundation. And Lauren, let's talk a little bit about that, a little bit about your work too, but also sort of this difference between food insecurity and nutrition insecurity.
Yeah, I'm really glad we're going to be able to dive into that, and it came up earlier. First of all, for those of you who don't know, the CDC Foundation is a independent nonprofit that was developed more than 25 years ago to support public health in general and the CDC's goals in particular. But in terms of the distinction, I think, and I think it was, Darius, you talked about it earlier, the distinction between having enough calories or having inadequate amount of calories versus the nutritional content of the food that's being consumed. And so it's quite possible to have adequate calories but be nutritionally insecure. And so I think this expanded conversation about what does nutritional insecurity look like versus food insecurity, I think, is an important distinction.
Mm-hmm. Yeah. Orrin Hesterman, founder of the Fair Food Network. Thanks so much for being here. And tell us about your work and especially what you've been doing in terms of nutritional insecurity.
Thank you so much. What a pleasure to be here.
Thank you. Got to lift it up, I think. There you go.
Okay, better. Great. Well, what a pleasure to be here, an honor to be here today. The Fair Food Network is here to grow community health and wealth through food. And I want to talk just for a minute about how we see food as medicine fitting in with our work at Fair Food Network. Most of the conversations today are about how food is medicine for individual bodies. We approach it as a system, that the same food we need as medicine for our human bodies is the same food we need for the health of our Earth's body and for the health of our communities. And so we really need to see this as a systems approach. And I'm very proud of the work that many of us have done together over the last many years in the food as medicine work, especially in the area of nutrition incentives. So at Fair Food Network, we call it Double Up Food Bucks, and simply SNAP participants have the opportunity to, when they spend SNAP money on fresh fruits and vegetables, they get additional money. Spend $20, get $20 additional dollars. Go home with $40 of fresh produce, and with a priority for locally grown produce. Now, nationally, this is now called the Gus Schumacher Nutrition Incentive Program, named after Gus Schumacher, a good friend of many of us, especially here in Boston. With Double Up Food Bucks, we see this as a win-win-win. It's a win because families are bringing home more fruits and vegetables, more healthy food. Farmers are getting additional income from the food that they can sell, and those dollars are staying within the local economy, helping to create economic activity, jobs, and income. So this win-win-win is an important way to think about food as medicine. What I like to say, and some of you have heard me say this before, you can either pay the farmer now or the doctor later. And at Fair Food Network, we believe that we need to be paying the farmer now.
Very good, nice. I wonder, we're hearing a lot about different approaches to dealing with the problem of food insecurity and nutrition insecurity to some degree today. But it seems as if there are a lot of different groups doing it and not sort of one cohesive effort. Would you call that a big obstacle? And if so, if not, what is the obstacle? And if so, how would you address it? What would you say, Lauren?
Well, I think that you definitely put your finger on it. And the CDC Foundation has been thrilled to partner with the White House to gather commitments and involvement in the conference that we've been talking about today, but also as a follow-on to figure out how do you maintain that momentum. And one of the things that we're looking to do is definitely not recreate anything that's existing, but what kind of action collaborative could be developed that would bring folks in from all the different sectors that you all have talked about, including healthcare, to be able to sort of maintain that momentum, to leverage best practices to ensure, as we heard in the prior panel, that community members aren't just advisors to something, but that they are truly the deciders. So not just advisors, but the deciders. So that level of community activation and engagement. So we're looking to partner with folks to be able to do that, and that's a major thrust of ours, is to develop that action collaborative that will be a big tent that can include both private, public, social sector.
Is that a big challenge, Rick, would you say? Sort of coordinating all the efforts, or how do you describe a main challenge for you?
I think there's a couple of things. We're very siloed in our approach, and there are some major players that really, when you put them all together, like, we actually have all the answers. We literally have all the solutions. Everyone just remains silo, and the silo widens the further you go down the who doesn't have the money and where does the money start at. And so from that perspective, you see healthcare major player, and we're engaged quite a bit with healthcare because 85% of our applicants have health insurance. And by the way, 40% are commercial plans. We are seeing this creep up into the middle class quite a bit. Very different from what we thought without the data. And then there's the government, and there's nonprofit. So when you look at all of those issues, when it comes down from a CBO perspective, Orr and I were in the back, we're talking, we're like, what is the problem? We said, well, number one's funding, number two's funding, and number three is sending us folks without funding, right? And so when you think about the fight in food insecurity to this point, which is why I'm so excited about this conversation, like, the business model for fighting food and nutritional insecurity is begging for money. I mean, when it gets down to CBOs, that is not sustainable, just the nature of the model in and of itself. So on the one hand, that's an issue for community-based organizations who have the relationships, who have the intimacy and can get the data. On the other hand, it's data. Right? So there was a lot of investment. I can get a lot of folks talking to me and U.S. Hunger about food and how do we get you more food, but not about data, not about technical investments we need to be able to, or just modern technical things that would allow us to run nonprofits and community-based organizations like the best brands in the world do. And we made that choice to invest in the downstream of the pandemic into data so we can understand, because it's really not data, their lives. And so I would say those are two very siloed areas. The funding is not clear. It is focused on the loudest solution. And then data, you cannot determine good ROI without good data. And so the community-based organizations have these relationships. They get these stories. They need help better documenting it. They need help better aggregating the data. They need help better understanding what are the right questions to ask and how do we connect that upstream to healthcare, to the universities, to government.
And that would help.
Quite a bit.
That would help address these obstacles that you're seeing. Yeah.
Yeah. It's not. What we'd find out is it's not about food. There's a collective ecosystem has to be addressed in tandem.
Right. Orrin, I know you mentioned the Double Food Bucks program and a potential solution, and we all know food in general is expensive, and healthy food is very expensive. So what that's one way of addressing it, but is that a primary issue, would you say, in terms of making sure that people can get the nutrition that they need?
So when we, early on at Fair Food Network, did our research to see where the most important work for us in this field would be, the two answers we got back from the community were all about access and affordability. So how are we going to create greater access, which is one of the reasons why the Double Up program is now not just at farmers markets, that's where it started, but now in grocery stores and expanding to different kinds of retail operations. Access is important, but affordability, as you said, is really primary. You know, rather than barriers, I think of opportunities. And I agree with you, Rick, that one of our opportunities is really that to weave a tapestry together is through research efforts. that we need better evidence that connects the food system work with the health system work, so we can bring together resources from food and agriculture and healthcare together. The other real opportunity has to do with public policy that can address affordability, accessibility, health. What we're really talking about is transforming a system here. And I cannot imagine how you transform a system without shifting public policy. And we have some great opportunities ahead. One opportunity coming this year is with the Farm Bill. And many of us can work together to address issues in the Farm Bill that can create greater accessibility and affordability.
If you were approaching me, Rick, with a pitch of why I should invest in food as medicine, what 2 data points would you tell me in terms of the return on my investment?
It is nutritional insecurity and accessibility and affordability in one. So the best stat that we've seen monitoring this through the pandemic the last 3 years is obesity. Obesity went from being 19 on our list in 2020. By March of 21, literally 12 months into the pandemic, officially, it moved to number 5. Last year it was number 4. This year, year to date, and that's with 30,000 applicants, it's number 3.
Wow.
So folks are figuring out how to survive. And when you combine that with skipping meals, moms and dads and grandmothers, which are moms 2.0, are skipping meals to make sure the kids are eating. They just cannot afford it. And so if you do not look at food as a major issue, you're going to worsen the plight of those very folks who are in the room talking about how we help them.
One thing I would add, and again, sort of pulling the threads from prior panels, is this opportunity for food as medicine and sort of the broader healthy food system to be an economic engine and an economic driver. So we heard about it in community, you talked about it with farmers. There's many states where farm councils have become the mechanism through which people are having these conversations because, regardless of, it's a bipartisan kind of situation to be supportive of, farmers and, especially, independent or farmers. So this idea of driving economic, not just inclusion, but economic productivity and economic sort of vitality is, I think, another way of getting people, into that conversation.
A data point that we have from evaluation on the Double Up program is that for every dollar of nutrition incentive money that's spent in a community, there's about a $3 multiplier effect of economic activity in the community. So I think you're absolutely right, Lauren, that we can see food not just as something for individual health, but for economic community health as well.
I wonder, with increasing attention, as it seems, there's a lot of activity in this space, there's a lot of attention in this space, that for-profits will be attracted to this as well as nonprofits. I wonder how you think it should be balanced to make sure that for-profits would approach this in the same sort of holistic way that nonprofits might, and how do we make sure that that's being done the same way, or what are your concerns about that or advice about that? What would you say? Lauren, would you like to go first?
Sure. I think we heard also in the last panel about the importance of understanding and discernment. So the way that nonprofits or healthcare settings do the universal screenings, do that kind of assessment around what people's needs and assets are. I think when for-profit entities come into the conversation, that it would be really important that holistic stance come with it, because only asking one question about the food insecurity is not going to then identify the associated housing instability or other aspects of economic instability potentially, or other sort of issues. So I think I would encourage a holistic and comprehensive approach to it, regardless of whether or not it's being done by a for-profit entity or a nonprofit entity.
Yeah, I'd agree with that. I'm actually very hopeful in this area. We're in a lot of conversations with a variety of for-profit organizations who really do want to help. They really do want to understand. One of the things we hear from them constantly is, we just don't have the data. We get a lot of anecdotes that are kind of passed off as data. Anecdotes aren't data. But we don't have the data. They're still a for-profit, so they have to be able to see the return on investment, even if it's a social return on investment. And that's why I'm so passionate about, we have to arm the CBOs with that ability to tell their shareholder story, their stakeholder story, and show their impact, their social impact in real time. Because there are corporations who really welcome that, and they know how to take that impact and laser it into their market focuses, which are all local and can be very different locally.
What would you say?
I mean, the way I see this is that at the end of the day, both the food system and the healthcare system are market-based. I mean, that's what's going to transform what we're talking about. It's not, nonprofit organizations are not going to transform the systems. It's going to be transformed because the marketplace becomes in alignment with some of the values and approaches. The role of the nonprofit sector, in my belief, is to innovate, to test, to provide the evidence, and to show both the public sector of government and the private sector models that work, so then we can work together to expand those models. And that's why we're really pushing on nutrition incentives so hard, because we know it's a model that works. And now it is time to figure out how to expand that model, and it's only going to work if government and the private sector works together with nonprofits.
Are you concerned about that at all, about the private sector getting involved without some guardrails?
I mean, listen, we've got partnerships with retail grocers all over the state of Michigan, and now increasingly all over the country, and they're good, powerful partnerships that are benefiting everybody. So it can work well.
Rick, of the lessons that you have learned, what would a main lesson be to other nonprofits who are either in this space already or thinking about it?
Yeah, collaborate. The problem's way too big, and we all know it. You know, the Orange and my organization, we know it. The problem's way too hard, and so resist that urge to silo, right? And unfortunately, oftentimes, the grants and the grant processes themselves silo you, right? If you told this guy and this guy, okay, we're going to give you $1 million. Key, you two have to work together and figure out a model that works. Guess what would happen? We would figure out a model that works. But grants don't do that. They lean to one person. Even the second organization is like they can be listed as a supporter, almost like a vendor of the process. And so we have to resist that urge to collaborate instead of silo.
Okay, anybody listening, $1 million right over here?
Or 2 million,
they'll figure
or 3
it all
million.
out for us. Okay, want to thank you all very much. This was terrific. We're out of time. I'm sure we could keep going. Thank you.
Another incredible panel. I want to especially thank Deborah and all of the panelists for their work. We now have a very special video to share from Boston Mayor Michelle Wu. While Mayor Wu's video plays, I'd like to ask our panelists to join me on stage for a conversation that I am very honored to moderate. We will discuss the important role of research in addressing our current health challenges. We'll have Dan Glickman, the former U.S. Secretary of Agriculture, a senior fellow at the Bipartisan Policy Center, the chair of the APCO Worldwide's International Advisory Council, and board chair emeritus of the Foundation for Food and Agricultural Research, Dr. Bisola Ojikutu, the executive director of the Boston Public Health Commission and commissioner of public health for the city of Boston, and Diana Johnson, the manager of the Food Initiative at the Rockefeller Foundation. And we'll get to welcome back to the stage Dr. Christina Economos, the amazing new dean of the Friedman School at Tufts. But now we'll watch Mayor Wu.
Hi everyone, it's Mayor Michelle Wu. I want to thank Food Tank, the White House, and Tufts University for organizing today's summit to spread the word on the importance of food and nutrition security in our country. Here in Massachusetts, nearly a third of our residents face food insecurity in the last year, and nearly half of all adults have diabetes or prediabetes. In Boston, we've created an Office of Food Justice and are partnering with organizations like Community Servings, Project Bread, Boston Medical Center, and more to do more to ensure all of our residents have access to fresh, nutritious, culturally relevant food. We're also proud to be home to hospitals that provide medically tailored meals through MassHealth. So I want to thank my friends and colleagues at the state for renewing Massachusetts' Medicaid waiver to ensure our residents can continue to access flexible programs for housing and nutrition supports at our community health centers across the city. From the Boston Public Health Commission to Age Strong and Boston Public Schools, we're taking a food as medicine approach to public health, partnering with local farmers and vendors, and adopting strict school nutrition standards to ensure that all of our residents can access fresh, healthy food to protect workers' rights, promote sustainability, and advance racial equity. As this movement continues to grow, we are committed to continuing to invest in food and healthcare at every level. And so I'm so grateful to Food Tank, the White House, and Tufts for creating space to discuss more opportunities and collaboration to achieve our shared goals of ending hunger and reducing health disparities everywhere.
Woo! That's great. Special thanks to Mayor Wu. Well, we know how busy she is. I am now excited to turn to this panel, which I've been looking forward to all day. So I just want to dive right in, okay? So Chris and Dan, I'm hoping to start with you both because I admire you both so much. So I'm excited to be on the stage. Research around, I guess the research approaches around nutrition and public health have really changed significantly over the last 3 decades. I mean, really in big ways. But it's only recently that the tools for research have caught up. So I'm wondering how that affects our ability to really bridge the gap between food and health and where we are today because of all this. So maybe, Chris, I turn to you first.
Sure, Tiara. Thank you for that question. When I think about the past 3 decades and the beginning of my training, I was reading a lot of literature on one-on-one behavior change, which is really important. But as the decades went on, our sort of the paradigm shift in research started to think about multi-level, multi-systems approaches, whole of community approaches, structural and social determinants of health. And as we began to think more broadly about what ultimately impacts our health, we needed to develop tools to measure those things. So when you think about the food environment or the food system or the built environment or measures of racism and discrimination, you need valid and reliable tools to measure those things in your research studies so that you can conduct, as has been spoken about, trials that produce the evidence. So, creating tools that are valid and reliable is a whole science in itself. And some people spend their time on methodology. We now have system science. We have big data. We have geocoding and GIS. We have lots of things now that we can use to really understand the big picture and the environment that we're trying to study. It doesn't mean we shouldn't still execute one-on-one behavior change. That's essential, particularly in healthcare. But the work I do in communities with disadvantage across America, it has a lot more to do with the environment and the zip code where people live and the structural and social determinants that are impacting their health. And so interventions like produce prescription and food as medicine that's working to sometimes grow the produce, distribute it equitably, and impact someone's diet at even more of a population level is really different. So the research has evolved a lot, the methodology has evolved, and I think many of us are working really hard to make sure that the research is producing the rigorous evidence we need to impact policy.
Thank you so much, Dan. You've worked a lot on this idea that we need more research to do what Chris is talking about.
First of all, thank you for having me here. I saw that 8 members of Congress are going to speak at this program, and I said we'd be here till 8 o'clock tonight. So speaking with experience, I'll try to not continue that trend. First of all, well, second of all, I have to say just a minute about Zoe. When I watched her, I thought to myself, you know, every family can, when you can be up and you can be down.
Yep.
And it doesn't kind of matter what you've done in your life. And it just struck me. I've faced that in my own family as well.
Sure.
How we have to realize that these problems are universal.
Absolutely.
So let me just say, one, it's great to be here at Tufts. I want to make one comment. That is, our federal feeding programs, the United States, are the best in the world. Nobody even comes close to America when it comes to SNAP, school meals. School meals is arguably the most successful of all federal social programs, and WIC. So, and there are many, many others as well. But we shouldn't be afraid to do research on these programs to see how well they are working and whether people are eating better and living longer because of the programs. I think the data will probably show it does work well, but we shouldn't be afraid to look at the data. And the data may show, for example, the consumption of sugar is something that we should be working against. Consumption of sodium. How do our programs do on those particular things? That is, the 40 to 50 million Americans plus the 20 million kids that are on our school feeding programs, what can they be doing to eat better, to reduce their sodium, and reduce their sugar, and to be healthier? And I commend the administration, particularly on the school meals program, for the work that they have been doing. These programs were established, interestingly, they have a national security focus to them. Why do we have the National School Lunch Program? It was established in the late 40s because half the people drafted weren't eligible for military service. So the head of the Selective Service came to President Truman and said, we got a problem here. And out of that came the National School Lunch Program. And basically all of our federal feeding programs are basically focused on having a healthier population so we can be a stronger country as well. The other point I would just make in terms of research is so important because it builds a bipartisan base. And Dari mentioned this at the beginning of his thing. If these programs, if our federal efforts aren't bipartisan, they are doomed to constant conflict and potentially failure. So I want to make one point that the previous one of the previous speakers wrote is that the problems affecting medicine, health, longevity, and disease affect all Americans, not just people at the bottom of the economic scale, although they are hit harder than everybody else, but they affect maybe not the very, very rich. All right, although I've seen some very, very rich people with type 2 diabetes as well. But these are programs that affect the health of America in general. So we need to look at this whole thing from this holistic standpoint of figuring out how we can have a healthier America by not being afraid to look at the data so we can keep our federal feeding programs as strong as possible, but also keep the programs bipartisan so Congress continues to provide the resources that we need in the future.
Thank you, Dan. I'm wondering if you can answer sort of quickly. You mentioned that research makes things more bipartisan, but when science is under attack, and especially by members of Congress, how do we get around that? Just quickly.
Yeah, this is a general problem. This doesn't relate to food, and it's part of the nihilistic view of life that we have seen in our recent politics, and it's not only just in politics, but it's in the faith-based community in many cases and elsewhere. And all it means is the old typing test. Now is the time for all good men to come to the aid of the country, for all good men and women to do the right thing.
Non-binary
thing. And, you know, all we can do is continue to try to preach the truth about science. And sometimes science makes it hard politically as well. One example is, for example, is the SNAP program doing its best to promote health? Or is it just doing more to promote quantity of food and not diet quality, a bigger part of it? Data will kind of demonstrate that. And so that's why research is so important.
So important. Thank you so much. Dr. Auchincloss, I want to turn to you. Chris talked about the idea of location really, really mattering, and your research centers around a lot. messy numbers, a lot around that. So I'm wondering what type of research can support efforts to reach communities that lack access to healthy, affordable, delicious food, when we're talking about communities that have been, just violated. They have been affected so much by marginalization and inherently racist and misogynist practices for decades.
Thank you so much for having me, and I really do appreciate that question. Before I jump into research, I think it's important to say that, so the Boston Public Health Commission is our city's health department, and it's one of the oldest, if not the oldest, health departments in the country. And fundamental to our work is health equity, and it is about dealing with structural racism. That's all we do for the most part. We're actually thinking about changing our mission statement to say that that is what we do. And we've been doing this for decades. It preceded me, and I think it's really important to say that, to put into context that we have done a lot of programming. And Mayor Wu, if you heard her talk, a lot of the things that she's talking about, having a mayor's office of food justice, having all the farmers markets, having the co-ops that was written in the Boston Globe this morning, all the work that's being done with Age Strong, working with the elderly, working very closely with Boston Public Schools, all this is really progressive work that's happening here in Boston. The problem is that we haven't made the progress that we should have made. And I think that's the issue. And that should tell us, no matter what research we put into this, we need to do something differently, And I really want to emphasize that when you look at the data that we've collected and you think about life expectancy around Boston by place, because you were asking me about place, the same neighborhoods, the same census tracts where life expectancy is low is where food insecurity is highest around the city. Okay, the same places where life expectancy is low, where we have high premature mortality, where we have high rates of diabetes, high rates of other chronic diseases. These are the same places where food insecurity is highest. So they're not disconnected, and sometimes we get closed in and boxed in by our work. And I have to be honest, I'm a health equity researcher, so I do a lot of work. And my health equity research prior to coming to this particular job was really focused in on structural determinants of health. So a lot of the things you mentioned about structural racism and its impact on HIV specifically. So myopically focusing in on HIV. And I thought to myself, a lot of what was happening in terms of people using the prevention, care, and treatment resources, a lot of the issues that we talk about with food insecurity, a lot of the issues that are sort of creating the problems that I just described about life expectancy and chronic diseases, this is about income inequality. This is about not having a universal basic income. This is about groups of people in neighborhoods who have no sense of economic mobility. If you don't feel as though you can attain, you can achieve, you can move forward, why are you caring about the quality of food you ingest? I mean, that's just basic. And I'm just going to speak as a doctor. I know from talking to many of my patients, I know that they were food insecure. Yet, they didn't talk about it that much. What they were talking about is, I don't have a job. Right. I had a hard time getting here. I'm going to go and eat the crackers that you guys have in the cabinet or whatever that'll fill me up. That's not the priority. So no matter what you're educating people on in terms of nutrition, no matter how much time you spend in programming, unless we have a structural change, unless we think about these issues of economics seriously and we commit to doing something differently, we're not going to get anywhere.
Thank you so much for outlining all of that. And I think, Diana, that brings me to my next question, which is we need a movement. We need a movement for things like a living wage and things that we don't normally talk about at public health conferences. So I'm wondering if you can talk to me around how this food is medicine movement has changed. You said particularly over the last 15 years, and I'd love to hear a little bit about that history.
So hi everyone, I'm really happy to be here on behalf of the Rockefeller Foundation. And I just want to go back to something that's coming up right now, which is data is very important, and the Rockefeller Foundation is investing in this space. We made a commitment last fall to mobilize $250 million to support the National Research Initiative for Food as Medicine in partnership with the American Heart Association. So we deeply believe in the need for data. But also, we need the storytelling, and that's what's really going to drive this data home. And I commend the two women who came here earlier. I think it was Zoe and Concetta, who came and bravely shared their story and their lived experience. And that's not lost on us, as researchers, that the data will get us very far. And there's a lot of things we still need to know about food as medicine. Even though it's very obvious food is good for health, we get questions from health plans about duration of interventions and the appropriate dosage and the cost and how it's going to bring down the cost of healthcare. But together with the data and the storytelling, that's where the movement building really comes in. And that's what the foundation is really looking at, is how to transform healthcare delivery so that it's serving people through food.
I love this idea of data and storytelling. And Chris, I'm hoping you can elaborate on what Diana said. And Diana, please feel free to jump in as Chris is talking. But data collection is really, really expensive to do well. And so you're seeing shifts around how it's becoming more multidisciplinary so that it can be done more efficiently, probably less expensively, and better, right?
Yeah. Yeah, we're seeing more and more calls for interdisciplinary research projects, and some are even multi-university. The largest grants out there, 8 to 10 million, often have 4 universities involved, and there's qualitative work and quantitative work. And just to build on, what both of you said, some of the research, I'm fortunate enough to be a co-PI on an NIH grant in the Mississippi Delta, where we're beginning with economic development. So growing the fruits and vegetables, living wage payment to the Black farmers there who want to get back into farming, but only want to do it if it provides a living wage and economic vitality and mobility, and it feeds the people right in the region, which then converts to a randomized controlled trial with the Delta Health Centers looking at, blood pressure and hemoglobin A1C, et cetera. So these are large, $6-7 million trials that some of us are fortunate enough to have, but it's because we're investing locally as well.
Sure.
Data is really important, but when the study is over, most of us want to know we made a difference where we were working. And in this case, it really does invest in people.
Yeah.
And as you said, I can't overstate the economic part of this.
Sure.
And so the more we can do projects like this, there's another one going on in California, and I'm sure there are many others as well. We want to be more aware of them, we want to be supportive, and we want to tell the story so that we can really get that multi-level investment, right, from seed all the way to society. And the only way we're going to do that, unfortunately, is with research funding.
Yeah.
It's really expensive to do this work, but if it's high quality and the measurements are rigorous, we're going to have excellent data to push policy forward in the next 1, 3, 5 years. So many of us are working in that way to really invest in the communities as well.
Absolutely. Thank you. Dan, you wanted to comment?
Yeah, this is such a complicated problem. Food is medicine, and it involves people's backgrounds, income levels, status, access. It also involves what you should eat to keep you living a long time. And all of that requires research. I just read 2 books, one by a guy named Peter Attia, Dr. Attia. You may have read about him, featured in the New York Times. He's got all these exotic new ways that you're going to live to be 125. And by the way, I'm buying all the books he writes. and then Dr. Mark Hyman, who writes about the same thing. The truth is we're entering this new era of artificial intelligence, and we'll be able to determine with much greater specificity on a precision nutrition basis what you should eat and what you should eat. It may not be the same thing. All right. So and the second factor of all of this is that this issue of healthcare costs is going to bankrupt us as a country. It's costing hundreds of billions of dollars for Medicare and private insurance carrier to deal with preventable diseases that affect the poor, the middle income, and the upper middle income. So as a practical matter, we're going to have to deal with this issue. It's not going to go away. So we're going to have to look at this issue holistically across the board, which is difficult because everybody comes at this issue from their own perspective. And H.L. Mencken once said, for every complicated problem, there is a simple and a wrong solution. Well, I'm not sure that's true here, because I think that's what research does, is try to give us better solutions to the problem. But we're entering, the bright side of this, we're entering a new era where the sky's the limit in terms of our scientific capability. What I'm not so sure about is what our political and social capability is going to be able to help us deal with the problems of average people and lower income people.
Sure. Thank you, Dan. Diana, I wanted to go back to you, and the idea of data plus storytelling is so powerful and so effective. And one of the things that I admire about Rockefeller is that you're collaborating with folks you might not have collaborated with a decade ago, like the American Heart Association and others. These sorts of unusual collaborations are key. Can you talk a little bit more about that?
Yeah, so with the American Heart Association, we are co-designing this Food as Medicine initiative to look at those hard questions. We're calling it the No Excuses Research Initiative. We're going to try to prove once and for all with definitive evidence that food as medicine is good for health, reduces healthcare costs, and reduces utilization of the health emergency room and other expensive healthcare services. So that's a wonderful partnership that we're kicking off, and we're excited that we were going to make all these research findings publicly available, because that's really important too. There's a lot of the sector that has data right now that is not shareable. And so one of our commitments through this research initiative is that it will be available, the findings will be available publicly. But another initiative I wanted to mention is, that was mentioned earlier by Representative McGovern, is our partnership with the Veterans Health Administration. That program is really significant, one, because we have a number of folks at the table that helped us to design it. Veterans, unfortunately, in this country face disproportionate rates of food insecurity and diet-related disease in comparison with the US general population. And we brought together veterans, clinicians from the VA, the Office of Food Security, which the VA now has and has established. Incredible. Ourselves at the Rockefeller Foundation, some researchers to support us, thank you, Dari, and other implementers, including About Fresh here from Boston, to help us design a prescription program that will reach 500 veterans in Salt Lake City and Houston. And we are centered on those research questions. Yes, it's going to deliver an incredible and important service for veterans, but we're also going to walk away with important evidence that this works. That's the hope.
I love it. That's so great. I want to shift gears a little bit, Basola, because you were on the front lines over the last 3+ years now. And I'm wondering if you can talk about how the city of Boston is thinking differently now about how to engage with communities because of the COVID-19 pandemic. It must be very different than it was in 2019.
No, it certainly is. And it certainly is, but it also certainly isn't. I should say that. Sure. Because it's not that we didn't know how to engage communities. I don't know that there was as much of an investment to do so. Yeah. You know, there's really, the COVID-19 pandemic really amplified the needs, so I think that's important. Just to speak about food insecurity during COVID, just within Boston, you probably already had data from Massachusetts. The Boston Public Health Commission did conduct a survey in 2021 looking at food insecurity across the city and found that amongst Black individuals, amongst Latinx individuals, approximately 40% said that they were food insecure, whereas amongst white individuals, it was 7.9%. I was actually a little bit surprised that there was such a differential, because a lot of people were suffering during COVID-19, just to be very clear about my impressions of that data. And interestingly, in terms of neighborhoods, Mattapan, Dorchester, and East Boston had the highest levels of food insecurity. So what was done during that period of time, during COVID, which we would like to continue if there's funding to do it, is that there was mobilization and empowerment amongst community coalitions, which was really key. And what they were doing was certainly trying to increase health education, health literacy. They were trying to engage people in research, so the initial COVID-19 vaccine trials. And they were boots on the ground when nobody else was boots on the ground at the time. Everybody else was afraid. So you had people like the Black Boston COVID Coalition, you had La Colaborativa, you had Equity Now and Beyond, immigrant organizations that were doing this work. But they were also connecting people to resources. Right. So they were bringing food baskets into people's homes. They were really doing the things that needed to be done to meet the incredible gaps. The problem, as we all know, is that when an emergency ends, the impetus to do this kind of work ends. And there's sort of a flat line that we get into between these emergencies. And right now, these organizations, they don't really have the funding to do that kind of work. And that work is so critical because they could be continuing. It's not like food insecurity went away. Maybe it decreased a little bit since the height of COVID, but it hasn't gone away. So then how do we, as a city, as a state, as a country, figure out how to maintain that type of empowerment and mobilization information amongst communities. So one of the things we're doing within the Boston Public Health Commission is we're starting a community health equity empowerment fund. So we have some money from the American Rescue Plan Act that we're going to be offering to communities to partner with community health centers to do this kind of work and to address issues like food insecurity. But it's not enough. Right. There has to be a concerted effort. And if I, could design a research study looking at that, I would really want to see how well that truly works long term. Sure. How is that sustainable? Is it the way to go in terms of addressing these overwhelming issues in terms of health inequities beyond dealing with COVID-19 and, say, vaccine uptake and access? Right. So to me, that's one of the things that I would do in terms of research.
But that boots on the ground, that's going to be effective no matter what. Those community coalitions are going to be effective no matter what. Dan, how do we get the politicians to get behind this kind of thing?
Well, first of all, we've had a coalition of urban and rural, liberal and conservative interests in this country that have fought for 75 years on food insecurity. I see my friend Rick Leach out there, who's been a leader in both domestic and global efforts on food. This is one of the few areas where historically there has been bipartisanship, and there has not been this excessive vitriol and polarization. But it's fraying now. So the most important thing we can do, Massachusetts is different because I think your politics allows you to pursue perhaps a more progressive agenda than maybe the country as a whole. We must preserve this bipartisan coalition for food and nutrition security. I don't think you can talk about food security without talking about nutrition security as well. It's just not volume of food, it's the kind of food intake.
Can I add one thing here? Because this is so important that is somewhat different in Massachusetts, but there was a report that came out by Blue Cross Blue Shield Foundation in collaboration with the Health Equity Compact, which is a group of 70 leaders of color. Many of them are leaders of color. I'm a member of the group. And it reveals some important facts, right? So we should all have a moral imperative to do the kind of work that we want to do, to address food insecurity, to address health inequity. But we need something more than the moral imperative. We need the economic case for actually dealing with this. So according to the data that they collected, it costs Massachusetts alone per year $5.9 billion to address years of life loss, premature mortality, labor force loss in terms of Black, Latinx, and Asian individuals within the state of Massachusetts. So inequities actually cost us as taxpayers $5.9 billion. This report is online. It's astronomical. And if you think about that just across the country, this is one of the reasons why we need to be thinking about strategies like working more collaboratively, like working boots on the ground, like working in a bipartisan way, because this is not just about one group, it's not about one political party, this is about all of us.
I love it. Perfect way to end this panel. Thank you so much. Huge round of applause for you all. Thank you. We're going to go now to part 2, but I want to thank you all for being here so much. Thank you. We're going to continue exploring questions around research in the next part of this session, so please join me in welcoming Dr. J. Robin Moon, a social epidemiologist and public health strategist with the World Farmers Market Coalition, Kim Kessler, the Assistant Commissioner at the New York City Department of Health and Mental Hygiene, and Dr. Lauren Feichner, the Director of Nutrition at Mass General Hospital for Children, and the Senior Health and Research Advisor for the Greater Boston Food Bank. While they're planning to take the stage, you can give them a round of applause if you want. While they're joining us in a few seconds here, I'd like to share 2 short videos from U.S. Congressmember Seth Moulton, who represents the 6th Congressional District, and Congressmember Bill Keating of Massachusetts' 9th District.
Hi everyone, it's Congressman Seth Moulton. We all know how important it is to eat nutritious foods. We all love junk food too every once in a while, I certainly do, but a lot of times I feel terrible after eating junk food. That's because it doesn't have a lot of healthy nutrients in it. And many Americans can't afford to eat anything but junk food. We don't have enough healthy options at affordable prices for Americans, and that's why the work you're doing is so important. I was very proud to secure community project funding grants for the North Shore Hunger Network. I've been visiting a lot of the food pantries and shelters and seeing the amazing work our volunteers do every single day to get nutritious food out to those who need it. A great example is the new storefront in Salem. I was proud to be there on day 1, And it's amazing. You go in there and you shop like it's a regular grocery store with great options. You're treated like a human being, and you come home with a great meal for your family. So keep up your great work. It's important. It's making a difference in people's lives. And I'm sorry that I couldn't be with you there today.
There's a decades-old adage that you are what you eat. And that's being proven time and time again through current research. And I want to congratulate the Tufts Friedman School for the symposium they're conducting, and Food Tank too for collaborating in this important effort. I'm Bill Keating, I'm Congressman from the Mass 9th District, and we found the importance of diet. If you go to your GP now, the first thing they're going to sit down and discuss with you is your diet. And they're finding out that that's more important in terms of healthcare outcomes than even genetics. The links to heart disease, diabetes, cancer, obesity are clear. Further research is going to tell us that there might be other possible links to autoimmune types of disease. So I want to congratulate you for the symposium. Know that we're working with you in the Biden administration in this important strategy, and good luck in continuing this important work.
For the Congress members. So this is a really important discussion. I'm so excited to continue it as we think about addressing the current challenges around food and nutrition security and the important role of research. So Robin, I'm excited to start with you because you mentioned this concept of a syndemic that is contributing to issues including nutrition insecurity and diet-related diseases. And I'm wondering if you could talk about what this means. I'm especially concerned for the folks watching online that they may not understand this concept of a syndemic.
Sure, thank you, and thank you for having me here. I am wearing the hat of World Farmers Markets Coalition today, and one of the other hats I had worn. I was part of New York State. I'm from New York City. New York statewide Medicaid 1115 waiver works since I guess 2014 through the pandemic 2021, and I just want to start by saying that we have made a tremendous improvement and progress in making food is medicine reality, and I've seen it. I've done the work. We actually invested money to do that. Having said that, I worked in the Bronx area, responsible, caring for something like almost 400,000 people, and this is a place you might have heard of, the Bronx, New York, through the pandemic, especially, where children pre-pandemic were food insecure, 39, almost 40%. So the syndemic, it means 2 or more epidemics are synergistically interacting to exacerbate the problem at hand, which is the in excess burden of the disease of the population. So, diet-related disease, like almost, I would say almost all our chronic disease problems are diet-related diseases. And then food security and the pandemic, and we've seen that, the multiple interaction among those 3 things and how it made things so much worse for some people, not others. So that's what syndemic means. So I just want to make a couple of points about the food as medicine. A lot of great things that are said today. I do want to caution the going forward, I recommend that we need to focus more on making sure that the food as medicine is equity-centered, because that is an assumption, and that is something not to be taken for granted. And also, if our assumption is if these people just get a little more produce, they will be healthier, I would say we're at a risk of reductionist, atomistic approach, even a little arrogant, I might say, because I've seen how hard behavior change is for human. It's absolutely, they need the access to the better food, healthier food. But for us to say right choice, as in somebody's making a wrong choice, or there's a right food, smart choice, as in somebody's making a dumb choice, that kind of value judgment will get in the way and hamper our effort to help those population, individuals in the population and families change their behavior, and that takes a longer time.
It's so important to talk about the semantics, the language, the vocabulary of all this, and I think we all get sort of caught up and not understanding. So if I can turn to you, Lauren, semantics are obviously important, but like you're seeing a lot of these things sort of intersect with your work. At the Greater Boston Food Bank, you saw how like the pandemic, syndemic, all of these things are affecting people. The right and wrong judgments that often get placed on people, these are all things that you have to interact with on a daily basis.
Yeah, so that's right. So people ask, why as a doctor at the Greater Boston Food Bank, and why would I ever say, yes, I'll be there one day a week in a warehouse of food? So the amazing thing about this food bank is that there's 30% to 40% what we send out to our distributors is produce. So that was really exciting to me. But the other part of this is that all food pantries, we try to have client choice so that people can choose their options. And yes, we mostly distribute nutritious foods, but we're not saying this is right and this is wrong. We want to give them dignity, and we know that going to a food pantry is difficult. The other thing that I would say that I love about this network, right, there's 600 distribution sites in Eastern Massachusetts that we serve, who serve 600,000 people. And I think the other panelists have said this before, but they really know the community, and they really value them, and they know their stories, and we want those stories to be lifted and part of the solution. We don't want to prescribe that for them. We want to hear it from them directly.
Absolutely critical to this, and we've been hearing it all day. Storytelling, equity-centered, community-centered, all of these things really need to happen. Kim, I want to take a step back, if we could, and talk about how we got here, because I don't think I understand it, and I went to this school. Why have our public health systems ignored food and nutrition for so long?
Thanks so much. I want to say it's just amazing to be here. It's really an honor, and it's been such an energizing conversation so far. And I think, that's just such an important question. I think that it goes back a little bit to what Robin was talking about, that we really all have a huge role to play in increasing the understanding that these issues, these inequities and health outcomes that we're seeing, and the huge burden of poor health outcomes that we're seeing is really about policies and systems and not about personal failings. And when we can understand that, we can really look at what are the solutions that we need. And that's part of why I think, looking at that bottom of the pyramid is really so important in terms of the food as medicine opportunities is so important to keep at the foreground of this conversation. Like, we really need to be recognizing how crucial having the strong and having strong and huge amounts of access to programs like SNAP, like WIC, like Child and Adult Care and Feeding Program that we know work is really the foundation that we're going to build upon for continuing to make these kinds of changes in the future. And really recognizing that while there's huge opportunities in the health systems and more like proximal to those ultimate health outcomes, we can't leave behind when we're having this conversation, we're feeling this momentum, those more foundational policies and systems that are actually really driving how we got here. And so I think, part of why those policies and systems are not as effective as they could be is because we've let them be fragmented and we haven't built that shared understanding around how foundational they really are to the outcomes that we all need and we all deserve.
I mean, that's so well said, but I think a lot of us don't get why these silos were created in the first place. And so I'm wondering from all of you how we break those silos. And I know it's a very simple question, we've been talking about it all day, but how do you each individually in your own work try to do that? Lauren, do you want to go first?
Yeah, so I wear two hats. I'm a pediatrician at Mass General, and I'm also at the Greater Boston Food Bank. And so in it myself, I'm joining these two worlds, the community and the clinical piece, and trying to do it. But we also wrote an editorial in the Globe yesterday, Katherine D'Amato, our CEO, and myself, to say at least in Massachusetts, we should have an office of food security so that we can all work together so that these siloed systems can be brought together. And there's been many conversations of cities doing this, but at least as a state, as a leader in this area, we could start there.
Thank you. Robin?
I would add to that. The system is working exactly how it's designed.
Mm-hmm.
So silos system isn't broken, it's working fine. It's been designed to be too efficient. I know Dari, to start us off, to talked about I guess Green Revolution. I will put the name there, but we got way too efficient, and it's really a balance between efficiency and effectiveness. And I think a lot of us mean efficiency when we actually say effective. And it's not to blame anybody here. We're so used to the way things are running. So I think it's really important to acknowledge that system is working as it's designed. Right. And something for the silos to be broken, something's got to give. And what is that thing that's going to be given up is something we need to figure out.
Robin's talking about revolution. I like it. Kim, what silos do you break in your own work?
I think this is a place, actually, cities have been really at the forefront of doing this for some time, and we've seen really over the last decade, cities kind of take the lead, I would say, in recognizing how cross-cutting food is and how much opportunity there is for change when we do kind of work together across silos. So in New York City and here in Boston, as we were just hearing about, are two of the localities that have had mayor's offices have kind of dedicated offices and point people that are trying to coordinate across city agencies and really do those experiments, do those tests, do that coordination that can show how we can have a more kind of integrated and holistic and effective approach. It's not nearly effective enough because we still have so many challenges, but we have many examples of collaboration, and just one I can highlight is we have a recent new program where we are coordinating with our public hospital network to try and bridge that affordability gap. There's been a lot of conversation about how much of this is driven by inequities, and we heard about income inequality, and we really need to also think about wealth inequality as even more kind of foundational. And so recognizing that, one of those, really probably the largest barrier to healthy eating is affordability. There's programs that thankfully happening at the federal level, like the GusNIT program that we should all celebrate and see as a major path breaker in terms of supporting nutrition security. But locally, we're looking at this new program that's for folks who may not have access to other programs, and looking at providing credits to people so that they can order groceries from a network of New York City stores and have those groceries home delivered if necessary. And the criteria for the program is being at risk of food insecurity, having reported a diagnosis of hypertension or diabetes, and being a member of our NYC Care program, which is a health access program that's run through our public hospital network. And so it's the program's run in the health department, but a lot of the referrals are coming through our public hospital network, and it's kind of recognizing the systemic barrier of affordability, and we're really looking forward to evaluating that and seeing what we can learn about making resources more readily available to people and how it can impact health.
That's so
Can I
exciting.
add one more thing about silos between research community and the community? The other hat I wear, I'm a senior advisor to Robert Wood Johnson Foundation's one of their signature program called Interdisciplinary Research Leaders. That's literally bringing interdisciplinary research into the community. It's community-engaged research. It's really hard to do. There's inherent power dynamics, differentials. So the money, research funding that's invested in the research and researchers must translate down to the community and disseminate in the language. And I don't mean English, Spanish, but that too, but language and language level that they understand, and really get it down to the ground. And somebody says C to society, that needs to happen from the community, and that doesn't always happen as we think it should. So that's another silo that we can break.
Absolutely, the ground up has to really happen. Lauren and Kim, if I can switch gears and talk to you both a little bit. Earlier on today, we talked about mental health and diet and nutrition and food insecurity and nutrition insecurity. And I'm wondering if you can both sort of touch on how food and nutrition really impact mental health. And it happens in a lot of different ways, whether it's about access and affordability or, actually what nutrients you're able to get.
Yeah, so we just released our third annual statewide survey on food insecurity in Massachusetts. And so what we found in that, this is the first time we asked about chronic medical conditions. And so we found 1 in 3 adults were food insecure in Massachusetts. Also 1 in 3 children are experiencing child level food insecurity, which as a pediatrician is horrifying and saddening. But what was very interesting, looking at chronic medical conditions, those who were food insecure had depression and anxiety rates that were double. These are 56-60%, and the general population, what we found in the survey was 30%. So I don't know if it's a chicken or an egg. I think you're worried about putting food on the table for your kids. You're going to have a lot of anxiety and depression. Being a parent, I have 2 young children, is hard, and then to worry about are you gonna provide enough food for them is extremely hard. So I think there is this chicken and egg cycle.
Yeah. Kim, do you wanna touch on that?
Yeah, I think we have similar results. We have an annual survey that we conduct in New York City, and we see increased associations between people at risk of food insecurity and diabetes and hypertension, but also depression. And so I think one of the things we want to evaluate in the program I was just mentioning, Groceries to Go, is asking people, there'll be a survey before and after participation in the program, and getting at some mental health indicators, but also financial stress and general stress, and seeing if the program helps to alleviate that, in addition to things like fruit and vegetable consumption, or at the aggregate level, some of the health outcomes that we'll have access to. And I think that's really critical to understand, and we need to think about food as medicine in that, with that kind of broader application. When we might be looking at some of these really clinical factors, and we need to think about things like financial stress and the sort of reality of people's daily lives and how they connect to health in designing the interventions and in designing the evaluations as well.
So smart, thank you. I'm wondering, when we're talking about research and how it needs to be funded, which we've touched on a lot here today, why does it matter where funding comes from, or how food as medicine is actually framed, or food as health, or all of the other terms we've heard today? Why does that matter when we're talking about this topic?
It's not either or, it's both and. Like Dari and others mentioned, when it's a critical need for the patient to have better nutrition, medically tailored meals are absolutely necessary. But a lot of the people we know who are what we call food insecure are not necessarily dying yet, and they have their other priorities. So they might be making the smartest choice they can make, which is to buy what they buy. So in that scenario, food is medicine. Like I don't like to take medicine. Nobody likes medicine, and food is more than medicine. Food is your identity. Food is your culture. So framing it broadly, again, it's not to say, food is medicine works, but putting in the context, it's almost sometimes irrelevant that the food is medicine approach works, because we have to think about the context.
Kim, you were nodding.
Well, I'm agreeing with everything that Robin says. I think it really is some of the issues of equity that she's mentioning, so that we really are not being too narrow when we think about this, and recognizing that context. What really are the barriers that people are facing, and how are those being considered in, what's possible for food as medicine interventions, what investments we're going to make. And when we think about research, we need to look at the people with the most barriers, not the least barriers, in terms of assessing effectiveness.
Lauren?
Yeah, I would say the infrastructure for that community-based organization when you are doing research with them is so important, right? So we wanted to do more data-driven methods at the food bank. Some of our food pantries only were taking their data on index cards, and others had really sophisticated Google drives, et cetera, or like Google systems to get delivery to them via a text message. So really investing in those smaller CBOs and giving them the tools so that they can participate, so we can understand the barriers of everyone. It's important.
Yeah, totally important. Thank you so much. So I've heard a lot today from people like Dr. Ojikutu earlier, from Kim, you said this on our prep call, that there is a lot of focus on the small changes that need to happen to get to where we need to go. but we also need, it goes back to revolution, we need a big systems change. So how do we get there? And that's my last question. So we can spend a few minutes on it. Kim.
I'm gonna echo the storytelling and really the organizing. I mean, part of today, like what I see, is the success of organizing, and we've had some successes, but the scale is too small and too slow for what we really need. We have to, be bold in saying how unacceptable our current realities are, and we need to organize together to demand a more accelerated change. And so everyone in this room is doing that, but tell everyone else that we need to do it and do it faster, I think.
I agree, and this is where I actually wear the Farmers Markets Coalition hat. Behavior change does not happen in a vacuum. It happens in a community with people you trust, and you must like what you eat. It's not enough that you should be eating the right thing, a healthier thing. You have to like it, and that takes time, and that happens in the community. If you, as my friend, try arugula that I hate, I'm gonna want to try it. Maybe try twice, 3 times, 5 times, and maybe I'll end up liking it. This is a small example of how things change. My behavior and everybody's behavior changes in the community.
Thank you, Lauren.
Yeah, so I think this unacceptable 1 in 3 people in Massachusetts being food insecure is just really unacceptable, and I think we all need to work together. I know there are for-profits in here, I know there are nonprofits in here, I know there's public sector and private sector, and so I think we all have to, this is a human right issue for people to have food, and so I think we all have to work together to create solutions, so.
It is a human rights issue. This is also what I heard, be bold. The current reality is unacceptable. I can't reiterate that enough. Do it faster and like what you eat. Thank you so much to this panel. I'm going to stay here for a second and talk about what an inspiring afternoon this has been. I want to give a round of applause to this panel and all of the panelists and moderators you've heard today. Incredible. I now get to invite my friend, Kat Okar, to help me close out this portion of today's program. Back to the stage when she has a second, but please make sure to stay with us. After the fireside with Kat, we'll have some breakout sessions, which will be followed by a fantastic reception. A big thank you to our catering partner, Rita's, for curating a delicious menu, and to our in-kind partner, Bonterra Organic Estates, for sharing wine, so wait for the wine to enjoy this evening. They have been farming organically since 1987, so a long time before organic products were as available as they are now. So I'm going to invite Kat up here once we move this chair. I want to give a shout out to the crew from Mode, too, who's been making everything run smoothly. And a round of applause for Kat.
No, the Mode people, right?
Yeah,
yes, deserve all the credit. They're incredible.
I'm excited you're back up here.
I know, great to see you again.
Before I go into my prepared questions, what did you think? What was
my gosh, so amazing. I mean, the energy is, if we could bottle it up and sell it, or, it would be amazing and spark such a movement as we talked about in the morning or the early afternoon. I just think there's so much potential, as I was talking about before. And I think it's so illustrative that every single person in this room, every single person listening and beyond can play a role. Small, big, it doesn't matter. If we're going to make change, it has to be together.
So if we want everyone to be involved in this White House strategy, how do they do that? So people watching online, people in this room, people who might not have ever been to a conference at Tufts before or knew who Food Tank is, how can they get involved?
Sure. So one of the things, as I mentioned earlier, we put out this challenge to the world, basically, earlier back in March. And our deadline for what we're calling commitments is August 18th. And so we're asking folks to think about big, bold scalable efforts that you can do within your own community, within your own organization, your private company, potential partnership you could potentially forge, and thinking outside the box and thinking beyond what we, the federal government, can do. And so we're asking folks, even if you're interested, if you're like, I think I have this idea, I think we could maybe do this in my company, we're small but mighty, or I just met somebody, Irene, I'm not sure if she's still in the room, who's releasing a book today as a restaurant owner. The expertise in this room is boundless. And so we're happy to help you think through kind of what your contribution could look like or what your commitment could look like. But there's also some huge players in this room who also have expressed interest in partnering. So I would encourage you to think about those partnerships and really leverage those and take advantage of their offer. And so again, I'd encourage you to visit whitehouse.gov/Hunger Health Conference. You can kind of scroll on there and check out and find where it says the White House Challenge to End Hunger and Build Healthy Communities. Fill out an interest form, reach out to us. When you fill out that interest form, I know we heard from our CDC Foundation colleagues earlier today, that's where it goes, and we are partners with them. We have an MOU with them, so we work hand in glove with them to facilitate commitments, whether it be big or small. And so would encourage you to think about kind of what you might do, because I think we're really trying to go for things that will last beyond any administration, that will be not just a donation here, a donation there, but something that's sustainable that will transform the system for good. Because we've heard over and over again, the system is ripe for change.
Absolutely. So I think one of the things that has been so encouraging to me is there have been unusual collaborations. We talked about it earlier today. Is that what drives you? Like when you see these really like people who would otherwise never have spoken to one another, and organizations and institutions and businesses who are coming together to make change?
Yes, I mean, that is truly what gets me out of bed in the morning. Even at the federal level, when we're thinking about, as I mentioned earlier, 20 federal agencies, 20 years ago, 15 years ago, maybe we just think about the Department of Health and Human Services and agriculture. We wouldn't even think about, maybe our veterans or our military families or the Department of Transportation or Housing and Urban Development. But everybody has to play a role here, and actually can have a really sustainable impact. When we think about the infrastructure of our communities, when we think about access to transportation, that all plays into this, as we keep hearing over and over again. This is a structural issue that really goes beyond the walls of the doctor's office in so many ways.
And it's so exciting that there's a lot of bottom-up, ground grassroots strategy being combined with the dollars, the power of the private sector in a way that I've never seen before. We've always talked about these public-private partnerships, but this is actually working.
Yeah, and I think what you're seeing, and you heard hopefully over and over again, is that the business case is there, or it's building. And I think, and then we also have research to buttress that evidence that's needed to make the business case even further. And so I think we very much are thinking about this not as like it's just a good thing to do and you're going to lose money, but this is good for people and good for business. The other thing that I heard that really resonated with me is the need for cultural competence, for cultural humility, that what works for one population or one person might not work for everybody. And so we have to be, that's why I think the research part is so exciting, but also why we have to really, as we talked about in the beginning, really make sure that we're incorporating people with lived experience into the conversation and into the decision making, but also making sure that we step beyond our own silos and think about, what the world looks like beyond our kind of sphere of influence.
Yeah, I think there's no going back to having conferences where people with lived experience are not part of the conversation. Completely. And that's so important. I think the question that a lot of us who were able to attend or learn about the White House conference last September are wondering, is it going to happen again, or do we have to wait another 50 years, Kat?
Well, I'm hopeful if we all do our jobs today and in the future that we won't need one, because we will have solved hunger and we will solve diet-related disease. So that is what we're driving toward, that we won't need another conference in 50 years, because we will say, remember when we had that conference and now we are a hunger-free country and diet-related disease has decreased. We're setting the standard for the rest of the world. So that's what we're driving toward.
And for it to go beyond this administration and beyond any administration, that's really what's important.
Yeah, and I think Secretary Glickman said this really well, and I think as you've seen others say, we often talk about this being a bipartisan issue, But frankly, it's a nonpartisan issue. This is about the health of our communities and our families. And so that's why we're all in the work that we're doing and do it every day. That's why I think people from both sides of the aisle, regardless of where you come from, can get behind so much of this work, because this is benefiting not just potentially bottom lines, but it's benefiting people's communities and families. Everybody has somebody who has had a heart attack in their family. Everybody knows somebody with diabetes. Everybody knows somebody who is worried about where their next meal is going to come from. And so it's not just that issue. It's everybody's in this together and has some sort of connection to it. And so I think if we ground ourselves in that unity and that connectedness, it will make us even more powerful, and that momentum will continue beyond this administration.
We are all in it together, as Kat has said, and I want to thank all of you for being here and being in it together with all of us as we've gone through such a wonderful day of panels and speakers and such great experts who have helped us get here. So thank you for all of that, and I want to give Kat another round of applause. Thank you for being here.
Well, I'm gonna steal the mic and just give Danny a round of applause, because she's amazing. And as well as Bernie and the food tank team. As everyone knows, they are incredible and unparalleled. And you often are asking the questions and don't get the accolades and kudos that you all deserve, because you're just extraordinary to work with.
That's very kind of you. Thank you so much. I do want to thank the food tank team, who are exceptional. I want to thank Mode again for making sure that the live stream and so many people could watch this. So big round of applause for them.
Danny, can I give one more shout out?
Of course.
And I just wanted to also, should have mentioned this in the beginning, but it was so awesome to see Congressman McGovern give remarks. I think everybody knows what a rock star, an amazing champion he is. We would not have had the conference without him, right. And I would not be doing this work without him. So I just wanted to make sure that gave him a special White House shout out. He and his team are just extraordinary and are a huge reason why we're here.
They are superheroes, as I said before. Finally, a big thank you to Stop and Shop Traditional Medicinals. This conference couldn't have happened without them, so thank you to all of them and our in-kind donors with their great food donations. For those of you in the audience, please stay seated for one more moment. For those watching via the live stream, thank you for being with us all day. We really enjoyed having you. Thank you for your comments on social media and for your emails. I've tried to answer as many of them as I could while we were here. You can email me any of your reflections that we can include in our write-up to the White House by just emailing me at danielle@foodtank.com. I almost forgot my email there for a minute. It's been a long day. So thanks. Let's give the live stream watchers a round of applause. Thank you. All right, so for those of you in the room, please stay seated for just another couple of minutes. We're going to give you instructions for the breakout sections. And again, this is really important. I think this is a lot where a lot of the critical work will take place. This is your chance to respond to what you've heard today, disagree.